Thank you very much. Thank you, Sophie. I'm here. I hope I can be heard. Excellent. Well, I'm delighted to be here, and I'm very honored that you've asked me to make a few opening remarks. And I'm also delighted to be in the presence of so many esteemed colleagues from the government of Indonesia and so many distinguished academics, researchers, and leaders of industry who are also joining us on this program. I have been interested in this topic for about 15 years, since I first got involved in trying to make consistent, properly coded patient electronic records. And I have been attending artificial intelligence conferences internationally since. But this is not a new subject. You can probably trace its origins for at least 200 years into the early part of the 1800s. And there was a woman called Ada Lovelace who is attributed with writing the first set of instructions for a mechanical calculating device. In other words, she wrote the first computer program. And if you think about it, AI is writing computer programs and generating tools for ever increasing computing power. And we have got to the point now where we have unimaginable computing power. We can almost consider ourselves as being able to do anything. And if we combine that progress with the progress that has been made in the last decades in the biological sciences, in nucleic acid research, genes, RNA, proteins, our integrated understanding and our reductionist understanding of biology, we can see that we are at the crossroads of transforming the way that we live and making lives better for everyone, particularly in health, in human health and in animal health and in the health of the planet. We have unique opportunities now. But this conference is focusing on the human health. So I will just make a couple of remarks about that. I think in the field of human health, we have a huge opportunity to research and develop the best applications of artificial intelligence and indeed the specific subset of machine learning when we're programming or we're training artificial intelligence to go beyond what it has been trained and to teach itself, to learn from examples it encounters in the data that were not necessarily specifically inputted as a part of the training. So that is very exciting. And that's going to be one of the first impacts that we will see, I believe, when we have the ability to use artificial intelligence to study images that we make from medicine. And these can be photographs of skin lesions, they can be obviously x rays or ultrasound scans or MRI, magnetic resonance scans, anything like that. There will be huge applications, as I think we will hear later. So I think the other area that we are going to hear about is um, almost the digital doctor, a protocol driven, symptom based, symptom coded system that can tell you if you need to go to hospital or if you need to wait a few days and see what happens. So I think there are very many applications that we're going to hear about. But just let me say one final thing. It would be against the progress of this field if we lost the confidence of patients and the users of the systems that are being rather brilliantly put together by, for example, the speakers on this program. So we want AI really to conform to certain values, values of fairness, values of openness and transparency, and most of all, ethical and treating patients' data with the privacy that the patients have a right to expect. So, having said all that, I still believe that we are on the verge of a breakthrough that will be as meaningful, as impactful as was the introduction of antibiotics into medicine about 100 years ago. And I think it could even be more transforming than that. And it's wonderful here to see so many experts prepared to share their insights and their learnings with us. And let us all hope that we use these learnings and insights wisely for the improved health of generations to come. Thank you very, very much for your attention and have a lovely and productive conference.
variety of topics, from the regulatory landscape to the latest breakthroughs in AI to the specific application of AI in mental health care. Each speaker will present for 20 minutes, and at the end, we'll have time for all of your questions. So without further ado, I would like to introduce our distinguished panelists and welcome them to the stage. So our first speaker is Bapak Roy Himawan, Director of Pharmaceutical and Medical Device Resilience, Ministry of Health, Republic of Indonesia. Bapak Roy Himawan will be presenting online via pre-recorded video. With us here today, we have Professor Bambang Rianto Trilaksono, the professor at the School of Electrical Engineering and Informatics, Institute Technology Bandung. Please welcome Professor Bambang come to the stage. Our third speaker will be Professor Song Sen, Associate Professor, Department of Biomedical Engineering, Tsinghua University. Professor Song Sen will be joining us online via Zoom from Beijing. Great, so we can start our session. Let me begin by introducing our first speaker. Oh, Song Sen is here. Please welcome Professor Song Sen with a round of applause. Good morning, Professor. So, we'll begin with the first speaker, Bapak Roy Himawan. So Roy Himawan, S Pharma EPT MKM, is a pharmaceutical professional with a strong background in pharmacy and public health. He holds a Bachelor of Pharmacy and apothecary degree from Universitas Gadjah Mada and a Master of Public Health from Universitas Indonesia. Currently, he serves as the Director of Pharmaceutical and Medical Device Resilience at the Ministry of Health in Indonesia with over a decade of experience. Bapak Roy has held various key positions within the ministry and has been involved in national health programs, public policy planning, and international collaborations. He is also an active member of several professional organizations, including the International Society of Pharmacoeconomics and Outcome Research, and the Indonesian Health Economic Association. Please, we will welcome Bapak Roy Himawan with a pre-recorded presentation.
Good morning, dear participants and colleagues. In this opportunity, Director for Pharmaceutical and Medical Device Resilience, Ministry of Health, would like to present the materials with the title Navigating Artificial Intelligence Regulation in Indonesia's Healthcare Sector. So I would like to bring the materials and to through these following topics. That first of all, I would like to start with the challenge and opportunities that we have related to artificial intelligence. So as you may see on the slide, artificial intelligence in healthcare is a unpromising situation that we already heard from Forbes that the 10 biggest trends that revolutionizing healthcare in 2024, being picked number one is generative AI in healthcare. And when we see about the market share of artificial intelligence in 2023, then we may have the number that globally, the increasing rate of CAGR of AI in healthcare market is tremendously big. That we see 36% of CAGR in global and 42.5% CAGR in Asia Pacific, make us understand that this is the new trend in our life. And when we see about the use of AI in various cases in healthcare, then we may see robot-assisted surgery, including virtual nursing assistant and up to the administrative work, is now have implemented the AI approach. And when this technology comes to medical devices, then we may see several variables should be considered whenever we want to tackle AI in a good manner in our regulations. We need to see the difference between traditional and software as a medical devices in terms of timelines, in terms of modifications, in terms of product, in terms of submission in our regulatory context, and also in distributions. As example, you may see for the traditional medical devices, usually they have longer development timelines that will usually take some years. But in this new kind of medical devices, which is implement artificial intelligence, we may see a short development life cycles. Then by this condition, in the terms of submission, we will see the big difference between traditional and software-based medical devices. Whereas in traditional medical devices, we may see the volume of submission is generally predictable. But for the software as medical devices, we may see the volume of submission is expected to be increased exponentially. That will put another burden or that will put another challenges to our regulatory system. So, however, we do see that AI applications in healthcare services not only providing us a huge implementation possibility, but also provide us a multi-sector benefit when we implement the approach of AI. With regard to the scope, we may see the AI may be implemented in the topics in the area of prevention and screening, also in the area of diagnosis, also in the area of treatment, and even in the enable us to do adaptive remote intelligence, equipping patients and care teams with social and clinical insights for more effective management that will put a better result to our patients. And when we see about the multi-sector benefit that provided by AI, we may see not only patients that will take benefit from the AI implementation, but also for clinicians or providers, and also for health system whenever they use the AI because they are being benefited by the operational efficiencies and also the innovation that bring by this technology. So by having that understanding, we would like to take your attention to Indonesia medical devices dynamics. That we see on the slide, you may see that the market of medical device Indonesia is constantly growing in a bigger number rather than the world number of CAGR. If you see on the period of 2021 up to 2025, you may see Indonesia recorded the number of 12% per annum, whereas in the world stated that the CAGR reached 6%. So this is possible because Indonesia have an increasing number of insured population, whereas in the 2024, we will have 98% of our population being covered by national health insurance. Indonesia also has expanding private providers that we see more and more private hospitals opening to most the urban areas. And because Indonesia still up to now have a rising prevalence of heart diseases that makes the continuous care should be available more and more across the nation. And we want to take your attention to the dynamics of Indonesia medical device market, that not only as the market, Indonesia has the capability to produce medical devices that having increasing capability from year to year up to now. So when you see the graph, you may see on your left side, we have the increasing capability not only for the low risk categories of medical devices, but also in the high-risk category of medical devices. And we also having an increasing number of domestic medical device licenses provided to our manufacturers. By having this, we can see the increasing capability of Indonesia has on medical device manufacturing. So by having the condition, I would like to draw your attention to the regulation in Indonesia's healthcare sector that will provide easiness for the developing of artificial intelligence. First of all, the very main basic principles that our ministry is encouraging now and implementing it now is a health system transformation, where when we want to make a better health services for our people through 6 pillar transformation, starting from primary care, goes to secondary care, supported by health system resilience transformation, financing, health talent, and health technology transformation that will incompletely provide comprehensive intervention for our people. So by having this transformation, the program is not only as stated on the paper, but also put on the regulation, which is the very basic regulation in this country is law. So in a Health Law number 17, which is stipulated in 2023, there are mandates for all stakeholders, not only governments, but also the society, the people, the academicians, the researchers, to do development and improvement of our health system through increasing the number of specialists and also researchers. There's also mandate to do development and implementation of health information technology. There are also mandate to do affirmative actions to absorb local production in our healthcare facility. And also there is also mandate to do more advanced approach, such as genomic approach, to provide our society with a more precise mandate. The mandate then being transferred, being materialized in a government regulation, which is number 28 2024 this year, that provides all the ministries and agencies to be more detailed to arrange the intervention incentives that needed to ensure there is a health supply in the country. So starting by initiative to develop and strengthening supply chain from upstream to downstream, initiated by research and development, including on medical devices, put to complement the prioritization on the use of local production, and also the existence of incentives and also ecosystems to do research in our medical device area. So by having this, we would like to inform all the colleagues, even though the regulation is in place this year, but the ministries had started the transformation since the last 3 years behind, where the ministries do intervention on R&D area, do provide policies on productions, and also do regulate the market access to improve the innovations and resilience in our pharmaceutical and medical device dynamics. In R&D, as example, the ministries facilitate the clinical trial, the ministries facilitate the technology transfer, and also strengthening the capacity of our laboratory. Not to mention strengthening the clinical trial ecosystem through the establishment of INACRC, Indonesia Clinical Research Center, and Indonesia Clinical Research Unit in several hospitals in Indonesia. In production level, the ministry put policies which give incentives for those who do local manufacturing, including to facilitate testing and calibration for those who produce medical devices. And on market access, the Ministry of Health provide some policies and regulate the implementation of substitution of imported product in healthcare supplies. And there is also implementation of increasing the use of domestic product, and the ministries start to conduct business matching to facilitate and to make connections between manufacturers and healthcare facility to have better alignment on local product orientations. So we would like to inform all the colleagues that in today's based on regional and global practices. We do coherent with those regulations that exist on the regional level, like we have on Asia Pacific, or like we have in Southeast Asia. And also we do adhere the regulation that exists on the global level, like what we have on WHO, on IMDRF, and also in GHWP. And to the note also that Indonesia has ratified ASEAN Medical Device Directives in 2018, which together with other 9 ASEAN member states, we have harmonized our medical device regulations in a single system. And by having that understanding, we do see that for medical devices on international standard, there is also several sure the safety, the performance, and the quality of the medical devices. And along with that standard, we do see there is several reference that we may take if we want to discuss with relate to the software as medical devices, or if we want to discuss about artificial intelligence or machine learning enabled medical devices, the new terms that being provided by the standard. We may see the ISO/NP/TS 23918, and also we may see the BS/AMI 34971 year 2023 with regard to the implementation of machine learning in artificial intelligence. We also might see the ISO 62304 with specific on software medical devices and SIMD that will put standard on how to develop software on the life cycle. And also we may see several standards like IEC 63521 and IEC 63450 with related to the machine learning enabled medical devices, performance evaluation processes, and also how to test artificial intelligence for machine learning enabled medical devices. So by having that understanding, we do see the main aspect that need to be considered when we talk about software as medical devices. We need to consider about the quality management system. We need to consider about safety and performance. We need to consider how the software had their own version and traceability, how is design verification and validation, how to do clinical evaluation, its risk management, and the cybersecurity. So by having this understanding, currently Ministry of Health is preparing the regulations and guidelines for software as medical devices evaluation, including for AI-based software. But this is to take note that it not hinders and it not stop the ministry to understand the new and recent technology with related to SIMD. So by having this condition, we would like to update you on the initial result that we have until now. So to create the AI, it should be based on the data. So by understanding this, Ministry of Health exhibit the platform that we call Satu Sehat, which integrate all health facility in Indonesia, including all the health industry players and including the people in one platform that we call it Satu Sehat. By having this platform, the ministry are able to have the data with relate to the patient, by like personal health record, by like their history on visiting healthcare facility, and also the history or the track record for their wellness or their activity to maintain their health status. The ministry also able to collect data from health facility, starting from primary health centers, clinics, private practices, up until hospitals, laboratoriums, and pharmacies. And also the Ministry of Health collect data from health industry players, such as insurance companies, pharmacist laboratorium, and those data connected in one single standardized platform that enable an interoperability and interconnectability between data. So then they will be able to do analyzing, able to analyze and able to provide in very supportive information for those who need the data. So by having this information, we would like to update colleagues that on the implementation of Satu Sehat platform, now we only connect with 28,000 health facilities being connected and actively sending data to the platform. So by having this on the picture, you may see almost all the province on the west side of Indonesia already implement the data connectedness, and now we are striving to have a better connection with our colleague that live on east part of Indonesia. And then, as we mentioned before, even though we are on the process to establish the regulation on AI for medical devices, MOH already acknowledged the existence of those devices, and we do provide the access for those devices to reach the health facility and to serve the people. That's why MOH have registered some of those applications as software or physical devices to be registered in Indonesia and to be utilized on our healthcare system. This is the example of two medical devices or SAMDs, software as medical devices, that registered in our ministry, like the diagnostic radiology medical devices that are able to display, annotate, and to operate assessment on volume rendering, and fusion of medical CT images as an aid during use by radiation therapy planning. There is also application that related to retinal diagnostic software devices, where the software helps healthcare professionals to analyze retinal images for signs of diabetic retinopathy and immediately outputs recommendations on referral to ophthalmologists that we believe will provide better services to our people. This is the one that have been registered in our ministry. And we do recognize several research and development activity also comes to AI area, where some of the project, as you see on the slide, related to digital pathology for laboratory 4.0, where the project provide digitalizations with AI lab, provide a whole slide image scanning services that do autonomous artificial intelligence solutions to help analyze to perform cell abnormality marking, so then they will be able to be interpreted better by doctors and physicians. There's also research on AI-based digital stethoscope to help the physicians to conduct diagnosis on respiratory diseases. That this is come from our university and now currently seeking industry partners. So we do hope that this information will provide you the latest dynamics on AI in our healthcare, including with the focus on medical devices. So then by having those information, we come to conclusion that number one, the massive various possibilities and challenges for numerous sectors, with healthcare being one of the central domains impacted by its transformative development. We also can conclude that the current stage of acceptance and utilization of AI in the healthcare sector in Indonesia, with focus of medical devices, remains in its early phase. However, it is worth noting that AI holds substantial promise in enhancing the provision of healthcare services within the country. And for the last one, AI regulation in Indonesia's healthcare sector is still emerging, with efforts focused on aligning the sector with broader international standards, as we see on the previous slides, and also to focus on ensuring patient safety, data protection, managing ethical concerns, and fostering innovation. So we do hope this information may able to provide you several idea on what to do and what is the latest development of AI in medical device in Indonesia. So then the discussion may come to a better result of the day workshop. This is the end of presentation. Thank you very much for your attention and see you again. Thank you.
Great. Thank you very much, Papa Roy Himawan. It's a very interesting presentation talking about the landscape in AI in Indonesia and also some of the recent developments and progress that Indonesia is making. So moving right along, I would like to introduce our next speaker, the gentleman to my right, Professor Bambang Rianto Trilaksono. So Professor Bambang is a professor at the School of Electrical Engineering and Informatics at Institut Teknologi Bandung and director of the Advanced Robotics Laboratory. He earned his master's and doctoral degrees in electrical engineering from Waseda University in Japan, and his research focuses on artificial intelligence, robotics, and control, with over 171 publications and multiple patents. Professor Bambang has been a key figure in AI innovation in Indonesia, co-founding the AI startup Riset Kecerdasan Buatan, and contributing to the national AI strategy, including AI-based COVID-19 detection. He has received several awards for his contributions to AI and robotics research. So please welcome Professor Bambang. The stage is yours.
Thank you, moderator. It is my privilege to share with you regarding AI and its application in healthcare. So here is the agenda of my talk. First, I would like to share with you about AI, machine learning, deep learning, and the recent development on AI, the so-called generative AI. Then I will discuss AI application in healthcare, its benefits, and I also share with you some experience on developing AI in healthcare, in detecting COVID-19 using X-ray and CT scan. Then finally, I will discuss about the issues, challenges, as well as real-life use cases. So first, let me start by providing the analogy between AI and human sensory, brain, and motor systems. So we as human perceives our environment using our eyes, ears, perhaps also skin with touch, nose, tongue, and so on. And then we send this information to our brain, and based on what we perceive on the environment or on the surrounding, then we use our motoric systems, hand, foot, body, and so on, to respond to the environment. So in that process, we do problem solving, perceiving and acting, learning, understanding, knowledge accumulation, as well as reasoning. So we try to mimic, to model the process that we do in our brain into a computer. That's essentially the easiest way to understand artificial intelligence. In the modern era of AI, we see some development on machine learning, deep learning, and generative AI, where we can teach a computer to have certain knowledge based on the trained data, so that when you have new data, the AI model that has been trained can inference the data, for example, to provide the prediction. And deep learning is just a subset of machine learning, which is adopted from our brain to provide some prediction. So in a deep learning model, we can, for example, solve a task such as regression, which can be single input and single output. You can also provide multivariate regression with multi-input and multi-output. You can also use machine learning and deep learning for binary classification tasks, and as well as multi-class classifications. And you can also produce a new data based on the data that you can train. This is another example in which we can use deep learning to do image segmentation on the right side, and you can also use deep learning to do the image colorization, or you can even do the to recognize speech, and to translate, for example, from one language to the other language. And we can also even generate image from text, as shown in the recent development on generative AI. And we also witness the explosion of large language model, in which it is a sort of deep learning algorithms that can recognize, to summarize, translate, predict, and generate text or other form of contents in the form of image, video, song, or source code, for example, based on the knowledge gained from the massive data sets that is trained on the large language model. ChatGPT is one of the most popular of large language model. And we see also some development on the so-called generative AI, in which you have an input in the form of text, image, audio, sound, video, and so on. And based on the foundation model that is trained using the data, you can produce text, image, audio, video, software code, and so on. And some of the popular foundation models include ChatGPT, Midjourney, Stable Diffusion, DALL-E, Gemini, Sora, GPT-4o, and so on. And the use of AI in healthcare, as already mentioned by previous speakers, is growing very rapidly. There is a greater potential than ever before for modernizing medicine through automated computer techniques to free up the previous time of healthcare professionals and support more precise diagnosis. These are some of the benefits of AI in the healthcare industry, including enhanced patient care, offering accurate information, improve healthcare experience, time saving by automating some of the tasks in the healthcare industry, reduce care costs and so on. And this is a survey from Minsky that mentioned about share of hours currently work that could be freed up by automation by 2030 for a wide range of healthcare occupation in selected European countries. As you may see from this slide, there are a number of operations that can be automated, such as preparation of medical equipment, medical assistance, and so on. And this the application of AI in healthcare, the potential application that include medical image diagnosis, which is one of the popular AI application in healthcare. We can also use AI in drug discovery. I have a PhD students doing AI in one of the steps that is required in drug discovery. You can use AI for personalized medicines, or you can even use a robot for remote surgery, for example, and so on. WHO approach for AI in health can be seen in this slide. So there are a number of tasks and in healthcare that can be assisted by artificial intelligence. And the recent generative AI in the healthcare industry can also be applied widely. Let me mention specifically about the multimodal generative AI for medical application. The one that was launched recently by Matt Gemini from Google that use various medical modalities and knowledge and produce a Matt Gemini model for by using some 2D and 3D data as well as gene in classification of application, in visual question answering, to the report, and so on. And this is the prompt that can be provided to Matt Gemini. For example, given the images, what are the radiology findings that can be predicted by a Gemini model? And the sentence below the figure is the response of Gemini model. And it is interesting that there is one particular response that is not given by the original radiologist report. Then I will also share with you our experience in applying artificial intelligence for COVID-19 detection during the COVID-19 pandemic, where I lead a national team in predicting the COVID-19 based on the CT scan, X-ray, and as well as clinical data from patients. And we put the model on the cloud, and we train the model from the data that's are collected from around 20 hospitals. So this is one of the output of our CT scan application of AI, where we can extract GGO area percentage, the number of GGO consolidation area, number of consolidation, peripheral, central GGO, and so on. And this is our pipeline for deep learning model in predicting COVID-19 using X-ray. This is the dashboard and our prediction of our AI machine learning as well as deep learning model. So lastly, I would like to share with you some of the concerns that may arise from AI application in the healthcare. One of the concern is in regard to algorithms auditing, as Stiadi already mentioned. A model should be transparent, should be auditable, and we are actually in the initial stages of research on model transparency and model auditability. Here is some of concerns in regard to trustworthiness in AI foundation model in medical image analysis, which include privacy, robustness, reliability, explainability, fairness, and some other aspects. We also concerned with the benchmark and databases that are used to train the AI model, because we observe some variability of human inputs, diverse patient population and imaging techniques. We also have issues in regard to ground truth in a medical data set that often require multidisciplinary approach. And of course, we have to concern with the clinical trials. This some of the recent research on generative AI models to improve fairness of medical classifier under the so-called covariant safe, because the data that are used for training the AI model can be different statistically with the data that is used in real-world applications. So there is an issue in this, and research is being done recently in solving this problem. Domain generalization, covariance shift, and concept shift, and label noise is also issues that is currently under investigation in the application of AI in healthcare. But there is a potential solution in the future in terms of healthcare AI strategy, standard collaboration, regulation, as well as funding for research and development. Here is some real-life AI use cases in healthcare in the area of CT image processing, ECG analysis algorithms to detect arrhythmia, and automating follow-up recommendation from radiology report. Just give you an example of real-life use cases in healthcare. Finally, I would like also to share with you, it is unrealistic to think about AI to replace human in healthcare. It might be safe to consider human and AI collaboration, and perhaps collaborative AI adoption that require a multidisciplinary approach. And I have to say that AI in healthcare will complement, not replace a doctor and healthcare providers. Thank you.
Great. Thank you so much, Professor Bambang Rianto Trilaksono. It's a very informative talk. We got to hear about the background of AI and the different types of AI and how different types of AI have different applications in the healthcare sector. And it was very fascinating to hear about the work you were doing diagnosing COVID-19. So now I'd like to continue to our third speaker, Professor Song Sen, who's joining us online from Beijing. Professor Song Sen, a tenured associate professor at Tsinghua University, is the deputy director of the Tsinghua Brain and Intelligence Laboratory, a researcher at the Tsinghua Medical School's Institute for Biomedical Engineering, and a member of the IDG McGovern Brain Research Institute. He received his PhD in computational neuroscience from Brandeis University, USA in 2002. After graduation, he completed his postdoctoral research at the Cold Spring Harbor Laboratory and the Massachusetts Institute of Technology. Professor Song Sen joined Tsinghua University in 2010 and has been mainly engaged in interdisciplinary research in computational neuroscience and brain-inspired intelligence. He has published over 60 papers in international conferences and journals. His paper on pulse time-dependent plasticity, published in 2000, has received over 3,000 citations. His Tianqi chip paper was featured on the cover of Nature magazine in 2019, winning the title of China's top 10 scientific achievements of the year and being one of the 3 major breakthroughs in the 13th five-year plan. So please allow me to welcome Professor Song Sen via Zoom.
Thank you. Can you hear me?
Yes, please.
Yes, thank you. Yeah, so very good honor to speak here. Sorry I couldn't come in person this time. It's been in two-body too many times this year. So my talk will be on computational precision psychiatry. So it's great to come after a talk that's very comprehensive in introducing all the areas. So I'll focus a little bit on our latest research in the brain area. Okay, so basically the disease I focus on is major depression disorder. So as you can see, it's becoming more and more prevalent around the world, and probably due to the fast pace of modern life. So I hope this is not a problem in Bali, since I feel really relaxed whenever I go to Bali. But unfortunately, in China, the prevalence is coming up, and it's reaching about like 10% now, so which is quite high. I noticed also in our students at Tsinghua University. So basically, the current diagnosis of major depressive disorder is basically the doctor asks you, right? So basically, are you feeling okay? So basically, they through these questionnaires and conversations, they try to assess you on 3 dimensions: depressed state of mind, lack of interest and pleasure, and decreased energy levels. But these things are all very subjective. And also, this so-called shame, right? So basically, people don't want to say I'm depressed. So they might not answer the questionnaires in the correct fashion. In the informal survey we conducted with hospitals, we see that the questionnaires, the patients often answer them, maybe deliberately in a misleading fashion. Also, in the treatment of the major depression right now, it's also very trial and error. So basically, the several drugs approved for major depressive disorders, they're mostly based on the serotonin hypothesis, but there's some minor differences. But for the patients, actually, some patients respond better to one of them. So what happens is they will first prescribe you with a one that's most often used. But then if you have problems, for example, you don't become better or you have side effects, then they switch to a different drug. But the problem with depression is that these medicines take at least 2 weeks to take effects. And so just based on the statistic in China, each patient needs to take about 3 medications and about 3 months to get actually the relief. So it takes a long time. And you can see the uncertainty in this process probably adds on, further makes the disease worse, right? Because they get these because they're worried at the first place. So the process of the diagnosis and treatment, it adds on to this. So millions of people around the world are suffering like this. So the trend in the field is that can we actually go towards a precision psychiatry, right? So you can see just now a textbook recently, and also in the National Institute of Mental Health budget, there's a big chunk towards this. So can we use actually, modern methods rather than just asking questions, right? Relying on informal methods. Okay, so we want objective kind of measurements. And I'll be talking about EEG, which is, I think, probably the most promising. But we also have eye tracking, which you can do on your cell phone, right? So that can be used for kind of screening tools. And you can take pictures of the facial expressions, etc., and voices. So those can actually be done very cheaply, massively on cell phones. Then you have FNIRS and functional MRI, which of course is a little bit more involved. So that's also been several companies funded recently, at least in the United States. For example, auto neuroscience is based on actually a research of Dr. Wu Wei, who was actually a student in our labs at Tsinghua University before he went to the United States. And basically, they found actually if you use MRI scans and use AI to interpret it, it can actually be used to help develop drugs and assess the effect of drugs on this disease. But we actually prefer EEG because EEG, as you can see on the left corner, it's relatively easy to deploy in the clinical setting, right? It's kind of cheap, and also you can wear it and do tasks rather on. If you just lie there on the MRI scanner, it's kind of uncomfortable, and the amount of tasks you can do is relatively limited. And there's actually a lot of information within the EEG signals in different bands. You can see that actually different bands tell you different information, etc. So there's a lot to be mined from this data. And we also use flexible skin-like electronic sensors we can put on people. So you can actually monitor this at home. You can get an ECG and also like skin conductance, these kind of measurements. These are especially important for emotions, right? So basically, it's very useful for diagnosing depression-related disease. So let me get into a little bit detail on how we are doing on the diagnosis. So basically, what's the problem, right? Why is it not being used widely right now? The main problem is that there's a lot of variability among different patients, right? So we want to get so our mission is to overcome these across people differences, challenges, and find a set of reliable biological indicators, right? So it can give the right drug to the right patient at the right time. Okay, the challenge is basically because of the individual differences. So to actually get at these, we need to do pre-training from multi-source data from large data set and have methods that deal with individual differences. So we have started to do these. So as you can see, actually, why do we use EEG? The reason is that especially for emotional disorders, right, to detect emotions, fMRI is not as good. So you can see on the bottom that from a large survey, actually, if you look at what areas get activated in your brain when you perceive positive or negative emotions, they are highly overlapping, right? Within each brain area, there are probably different cells that respond to positive and negative, but at the fMRI resolution, it's hard to see. However, if you look at the temporal dimension, right, the time, from the EEG signals, you can see actually the differences, right? You can see on the top that from the frequency response or the temporal domain, actually negative and positive, they all look different. Okay, so that's why we prefer to use EEG for emotional related things. So there are a lot of dynamic properties in brain waves at all different time scales, right? Even if within fMRI, you can see there are the switchings between different states. And this kind of switching actually go down to very fast, about a couple hundred milliseconds. You can see there are actually a lot of changes happening, right? So we can use all these dynamic information, all different scales from EEG signals. So we started to develop a ChatGPT-like, transformer-based AI model for EEG. So we can take because it's kind of basically, you can think of like this temporal information as individual tokens, right? They're in a temporal sequence. So that's a little bit like a language. You can talk about a language for EEG. So that's why we use these technologies, which were originally introduced for modeling languages. So you can see actually by looking at these switchings in detail, we can figure out signatures for you to tell about the emotional states, right? For example, you bring into the bottom corner microstate C, right? So this is a temporal pattern that's centered on the back of your brain. Actually, so basically, people have done it, and it corresponds to a particular set of brain areas on fMRI. Okay, but if you do this, you can see for the negative and positive, this is the dominant state, right? So you cannot tell whether it's positive or negative emotion. You just know this person is getting emotional. But from the left, you can see actually if you look at these switchings in detail, you can see after 96 milliseconds, if it's a positive emotion, then it switches from this assessment state to the left side, which gives you the answer, right? So it's a positive emotion. For the negative emotion, after 48 milliseconds, it switched to the right side. So basically, there's both a difference in the time, right? The negative emotion is faster. It's probably because if there's a danger coming, you want to quickly make a response. Also, actually, the location is different, right? It's the right side versus the left side. So from this kind of, you can mine these kind of switching patterns and the brain activation patterns to kind of get at the diagnostic words, right? And then the words you can piece them together into sentences, etc. Then that lets you to understand the emotional state of this person. So to get at this individual differences we use across individual algorithm designs. Basically, we want to extract the common components from each individual, right? And then focus on these common ones rather than individual differences. The individual differences we can use later, but first let's get the common components. So we again use the contrastive learning methods borrowed from the AI field, and also actually more from the to deal with natural images. So this is from the self-supervised learning field in artificial intelligence. You can see after we extract the common components from people, we can actually now start to visualize these signals in this abstract high-dimensional space, right? You can see in this space, these individuals actually cluster, right? On the left side, you can see these are the patients in the dark blue. These are the patients that have the depression diagnosis, right, from clinical methods. And on the right side, the gray ones are actually healthy controls. But you can see, interestingly, on the light blue are actually these people who used to have depression, but now they are considered cured, right, after taking drugs for a while. So basically, the goal is to move from the left side to the right side, right? You can see very clearly in this visualization the trajectory of this patient, right? For example, I just give an example here. So this person took drug A for a while. So he started to shift it towards the right side, which is the right direction, right? But he got stuck after a while, right? So afterwards, they switched him to drug B, right? You can see that he got halfway. Then after drug C, it finally got cured. So you can start to have this very individualized trajectories to help guide this treatment process. Okay, so in the future, we hope also to put more other diagnostic features like the eye movements, ECG, etc. together, right? Hopefully to let us decide at the first place, whether drug A or drug B is better, right? So these kind of things are starting to become possible with these more objective measures. Okay. And finally, towards treatment, we had this interesting music workshop at Bali. So basically, we're starting to, especially for these people who are not really serious, right? As a supplemental treatment, we want to use the music, but personalized to this person to help with these kind of treatments. Okay. Thank you very much. That's all for today.
Great. Thank you very much, Professor Song-Sen. We're very grateful to have you involved in our session this morning. Professor Song-Sen is really involved in the development of our center here at Tsinghua Southeast Asia Center as one of our faculty fellows. So he travels often to Bali, and he played a big role in developing this event for us here today. So we're very thankful for your help, Prof. Song-Sen.
Thank you.
Please don't go anywhere. We have the Q&A session. That wraps up the three speakers that we have. If there are any questions, we can take questions for Professor Bambang and Professor Song-Sen. So you can ask your questions. Kalau Bapak Ibu mau bertanya memakai bahasa Indonesia, bisa juga, silakan. Yes, we have some questions.
Bismillah, Assalamualaikum. My name is Hamen from Adam Malik Hospital. I'm a radiologist. So, of course, my main interest is about the imaging in AI. I want to ask my question to Professor Bambang. It's about how hard is it to develop AI by ourselves? Because, I'm looking at radiologists from abroad. They're already using all the automated programs. We do calculation ourselves, we do it manually, we do the contouring manually, we do the segmentation manually. But that's the problem with the commercially available AI program is they're quite expensive, and I think that hospital management is not going to spend some money just to make our job easier. So I think it's more beneficial for us to develop our own AI, but that's why I want to ask Professor Bambang, is it feasible for a hospital to develop their own AI? Maybe with cooperation with ITB, maybe like that, because we have ideas, we have very big data, we have maybe 100 gigabytes of imaging data a day. So all the data is currently wasting with nothing to do with the data. So I think it's my question. Thank you.
Great. Thank you for your question. So the question is about the challenge of moving from these manual practices to using AI, and using AI in a cost-effective and affordable way, and whether that solution is, do we develop the systems ourselves, or is there another method for using AI in an affordable way? So please, bro.
Thank you for the question. I believe we can develop the AI imagings by our own, based on the, at least from our experience in developing AI for detecting COVID-19 from X-ray and CT scan, and we obtain roughly 94% in terms of accuracy when using CT scan, and slightly below 90 in terms of the accuracy when we analyze or try to predict the COVID-19 from X-ray. But the accuracy, the relatively high accuracy is being added by some clinical data, such as the age, gender, whether you have a coach or not, and some other clinical data. So from our experience, we can combine the imaging data with those from clinical data to obtain a relatively high accuracy in terms of predicting COVID-19. And I believe we can also work together with from your side, where you have a large number of data sets, and there must be a close collaboration from the beginning of the research and development between the healthcare professional, such as radiologist and medical doctor, because we have to have a ground truth label or annotation for medical imaging, so that we can train those labeled data in supervised machine learning or deep learning to obtain the AI model that can have high performance when applied to new data in terms of medical imaging. So that, in short, I fully appreciate the intention to work together. Perhaps we can also invite some other institution to do the research and development in this area. And yes, I agree that some of the AI software for medical imaging is quite expensive, and by doing ourselves, we can overcome the expense that we have to spend on the commercial uses of AI. Thank you.
Yeah, thank you. Good. So that's a really great answer. It's that we don't have to do it ourselves. And it doesn't have to be very expensive, but we can find these partnerships and collaborations with academia, computer sciences, data sciences, and it's great to hear that Professor Bambang is open to these collaborations. Professor Song Sen, do you have a few words on this question to add?
Yeah, I think probably my student knows more about this. He developed some of the earlier software while in our lab, but he has since gone on to commercial companies. I think my understanding is that one of the difficulty in academic research on these is basically the last mile is often difficult. So you can get it to be quite high, but in order to get it really good, you need a lot of data, which sometimes is beyond the capability of academia.
Great, thank you. Great, good. Is there another question? Please.
Thank you. My name is Dr. Yudi from National Cancer Center Darmais Hospital, Jakarta. I have two questions. The first is for Professor Bambang. How about the development of the AI for histopathological biopsy in cancer? Is there any development for the AI in the diagnosis for cancer in histopathological? And the second question is for Professor Song. It is interesting that we can use you presented that using AI in mental disorders diagnosis and therapy. So my question is this patient all the patient is all the same sex or same gender, or is this the same race, the same race and the same religion? Is it only in China or in other countries? And is there the patient have cancer in the mental disorder? Thank you.
Great, thank you. So we have two questions. The first is about the development of AI for diagnosing cancer. And the second is about the studies in mental health around the study population around gender and race, and whether cancer has been included in these studies. Please, Professor Bambang first.
Thank you for the question. I'm not an expert on healthcare, actually, but I read some papers on AI for the cancer diagnosis. Even there are a few startups that do AI for cancer diagnosis. So that's perhaps the short answer to the questions. Thank you.
Thank you. And Professor Song Sen, if you could talk a little bit about more
yes,
about
so basically I talked about two studies, right? One's from auto neuroscience, that's of course in the United States, so probably more races. For the EEG study I presented is actually a collaboration with right now one hospital in Beijing, so that's mostly Chinese, of course, but different sexes, of course. Regarding the cancer question, actually it's quite interesting because of course if you get cancer or if you get other major disease, very, very likely you'll get depressed, right? So I think in our cohort there are cancer patients, but we didn't select for that selectively. But in the future, I think that would be a good way to go, like depression accompanied by other major disorders might be different from young people who just get depressed because of life stress. So that could be looked at in the future. So I think for different races, different populations, we have to redo the study. Basically, the method is general, but the features, etc., might have to be individualized towards each community.
Great, Thank you. Could we have our next question? I believe you have the microphone. Please.
Hi, thank you. My name is Aldi from Kemenkes, Cipta Mangunkusumo Hospital. Perhaps, thank you first of all for Professor Trilaksono and Professor Sen for sharing such an enlightening information. I think this is not a question, but more like complementary information. I think what the two presenters have briefly covered during the presentations, in my own experience, is the potential of AI or machine learning in providing prognosis of our patients. I work closely with kidney transplant patients, and it is important for us to actually allocate the right donors into the more successful recipients. And this has, machine learning has been utilized to provide this. So what we did was we gathered this information, we did a systematic review, which was currently under review in American Journal of Transplantation, and we found that the machine learning actually provides a better prognosis in 5 years patient survival in kidney transplantation. Now this is a crucial information since we probably will have a better idea of which organs to allocate to which recipients. However, I think, again, I highlight your point of view, Professor Trilaksono, in terms of taking this with a pinch of salt and actually applying it in our center. And I think the role of doctors is crucial here, because those data is made in countries where they have deceased donation or donors from cadaveric or dead donation after brain death. In Indonesia, we don't have that. So if we use that, then our patient will actually end up in dialysis, dying, instead of getting new organ and transplantation. I'm just highlighting the role of two crucial elements in implementing and using machine learning and AI. I think that's my point. Thank you.
Great, thank you very much. From our speakers, do we have any response?
Yes, I think actually makes a lot of sense, especially, for example, mental disorders, it's highly cultural and society dependent, right? So it needs to be with the doctors. I said the interview method is kind of subjective, but of course it's very important, right? Because we only know this person is depressed, but we don't know why. So asking these questions are still very important. So I think at least in psychiatric disorder, I don't see AI replacing doctors anytime soon. I probably will never. It's actually an important supplementary method.
Great, thank you. I know there's a lot more questions that we have. Unfortunately, that's all the time we have. Professor Bambang will be around this afternoon to answer any of your questions. Professor Song Sen will be coming to Bali often, and if you want a connection, you can connect with him through me. I'm happy to connect you. So that ends the first session of today's event.
Thank you.
Thank you, Song Sen. I think it was really great. We heard from Roy Himawan about the applications of AI, the speed of the changes that are coming up, how it's changing developments, upgrades and improvements of medical devices. There's applications in many areas. And we heard about what the government is doing to transform the healthcare system and strengthen supply chains, and seeing the progress that Indonesia is making to keep up with these changes. We heard about the background of the applications of AI, particularly in diagnosing COVID-19 and many other applications. And then we heard a very specific case study around depression and how we can move from, how AI helps us move from more subjective trial and error to very personalized, objective, and accurate results. So thank you very much, everyone. This concludes our session. I will hand it back to our MC.
Thank you, everybody.
Thank you.
A round of applause. It was a very fruitful discussion, I should say. We were just about to get to the gist of more things, but I do understand we have 2 more sessions. Ladies and gentlemen, to keep our program today punctual, it is now time for, I will not call it a coffee break anymore, it's a toilet break, because we've cut down the time to 10 minutes. Jadi kami persilakan Bapak dan Ibu bila harus ke belakang dulu atau sambil mengambil makan dan minum juga boleh dibawa ke dalam ruangan. So I will see you in 10 minutes and we will move on to the next session. Thank you very much.
Ya, baik Bu Wiwi, terima kasih waktunya. Tadi saya lihat ada rekomendasi dari mahasiswa terkait saya mengenai tadi Tengmas ya. Ini pada dasarnya memang begini Bu, kemarin itu memang beberapa
Ladies and gentlemen, we have 4 more minutes left before we go into our next session. Just a reminder that our next session will be commencing in 4 minutes, and that when you re-enter the auditorium, we ask that all handphones be silenced. Thank you. Ladies and gentlemen, a gentle reminder that we are about to begin our next session in 1 minute. So we would like to invite everybody back in the Awan Auditorium to please take your seats, as we would like to keep today's program punctual. Thank you very much. Bapak dan Ibu yang kami hormati, bagi yang mungkin berada di area pintu, agar dapat segera memasuki ruangan dan menempati tempat duduk Anda, yang masih berdiri di dalam ruangan auditorium awan, kami persilakan untuk juga segera menempati tempat duduk Anda. Ladies and gentlemen, for those of you who are in the doorway, we would like to invite you back in, as we would like to keep our program today punctual. Thank you very much. Baiklah, kita akan memulai sesi berikutnya, and we're still waiting for some more people to come in, but I will just move on with today's second session. Welcome back to the Awan Auditorium. We are now moving to our next agenda. It is now our second session, and I would like to invite the moderator of this session, Dr. Donna Arlinda, who is from our Ministry of Health. So Dr. Donna Arlinda is an experienced health administrator and clinical researcher with a background in medicine and bioclinical science. She holds a Master of Science in Pharmacology and Toxicology from Thammasat University and a medical doctor degree from Universitas Indonesia. Dr. Donna currently serves as the head of administrator for the Health Policy Agency under the Ministry of Health of the Republic of Indonesia, and her role as the lead of Clinical Operations Department at the Indonesia Research Partnership on Infectious Diseases, INA Respond, led her to manage and coordinate numerous clinical trials, particularly in infectious diseases. Additionally, her research focuses on COVID-19, HIV, and tropical diseases, with numerous publications and international collaborations in these areas. Ladies and gentlemen, Dr. Donna Arlinda.
Assalamualaikum warahmatullahi wabarakatuh. Bapak Ibu, selamat pagi menjelang siang ya, jam 11 nih kita. Sesi kedua ini saya pikir sangat menarik, terutama untuk para rekan-rekan radiologis ya di rumah sakit atau klinisi-klinisi di rumah sakit, melihat bagaimana pemanfaatan artificial intelligence AI dalam imaging. Izinkan saya untuk melanjutkan sesi ini dalam bahasa Inggris, Bapak Ibu. So good morning, everyone. Thank you for participating for today's session. So the second session will be discussing on how we utilize artificial intelligence in imaging. I think we have 4 speakers, yeah. But while the 3 speakers will be joining online, we have 1 speaker that is present with us today. I invite Mr. Fang Zhuo to come to the stage with me. Yes, please. I'm sorry for the mispronunciation, yeah, for the name, Mr. Fang Zhuo Liao, yes. In this session, the topic will encompasses MRI and neuroimaging, enhanced qualitative MR imaging, introduction to China's radiology AI utilization, and AI in action streamlining healthcare systems for better outcomes. Now, without further ado, let's dive into our first topic, MRI and neuroimaging, which will be delivered by Professor Qichuan Tian. I'm sorry really for the mispronunciation, yeah. Professor Qichuan Tian is an assistant professor and principal investigator of the School of Medical Engineering at Tsinghua University, and also a principal investigator of the Tsinghua Laboratory of Brain and Intelligence, and a junior fellow of the International Society for Magnetic Resonance in Medicine. He received his Bachelor of Engineering degree from Fudan University in 2011, and Master of Science and PhD degree from Stanford University in 2013 and also 2017. He conducted master's and doctoral researches in the Department of Electrical Engineering, and the Lucas Center for Imaging of Stanford University under the supervision of Professor Brian Wandel and Professor Jennifer McNabb. Without further ado, Dr. Ki Yuan Tian will be presenting online for the next 20 minutes. Please, Professor, if you're ready, the floor is yours. Thank you.
Yeah, thank you. Thank you. Can you hear me? Can you see my screen?
Yes, we can hear you clearly, Professor. Go ahead.
Yeah, thank you very much for the invitation, and thank you, Dr. Song, for the invitation. And I'm very glad to give this presentation. I actually visited Bali in the summer, and it is my first time to Indonesia, and it is a great pleasure. The title of my talk today is Intelligent Human Brain Magnetic Resonance Imaging. Basically, it's artificial intelligence for neuroimaging. As the moderator, I introduced my research focus is mainly artificial intelligence and neuroimaging or tools. And our that's the tools we use, and the application we focus on is neuroscience and also brain diseases. So let me continue. And actually, we talk a lot about the artificial intelligence, but here is a comparison of the artificial intelligence and the natural intelligence. And this is a very important event for the development of the artificial intelligence or the history of the AI, because that's the first time AlphaGo beats won the best human Go player. That's the first time. But the thing is that when we are amazed by the power of AlphaGo and AI, but that's the power the AI was using back to the 2017. So AlphaGo at that time used like 2,000 CPUs and 300 GPUs. But like Lucido only has like 3 pounds of the brains and a cup of coffee and a little bit lunch. And that's equivalent to all the powers and the money spent on the AlphaGo. So my point here is that the natural intelligence is still very, very powerful and power efficient. So that's because our brain is very complex. The function is complex. That's because of our the structure is complex. So this is the basic unit of our brain. That's the neuron. We have the cell body, which is processing the signal. We have the axons, which are responsible for the signals communications. But if we look at the macro level, we have the like a gray matter outside of our brain. That's called the gray matter, and we have the axons in the brain. That's the white matter. Because it's myelinated, so it looks white in the photos. So the white matter fiber pathways are actually make up a very complex like a communication system. That's like our fibers, Wi-Fi's. So each cortical regions is like a computer or laptop or the cell phones we are having. And then like all the fiber axons are like all the optical fibers and the Wi-Fi system we are having. So this network is very important. It's sometimes called the brain network, brain wiring, structural connectivity. It's critical in our ability to think, feel, and perceive. So we know that if the gray matter has some issues, the brain, there is some major diseases, but also it's the same for the white matter fiber pathways. If the network is broken, there will be also major brain diseases. So like the focus of my talk today will be the diffusion MRI. So we have different modalities of MRI to image different function or different properties of our brain. So we can image the anatomy, we can image the function, using functional MRI. And diffusion MRI is mainly used for mapping the microstructure of the brain and also the structural connectivity of the brain. MRI is very unique. It's non-invasive. There's no harm, and diffusion MRI is the only in vivo method to map the whole brain human connectome. So the idea is very simple actually, because there are a lot of water molecules in our brain. So the water molecules are moving randomly in our brain. But if the random motion is restricted by fiber pathways, for example, the water molecules move faster along the fibers than across the fibers. So if we can move the water rate along many directions, so we can compute the water moving rates along different directions, and we can fit some models. And if we know the directions the water molecules moves the fastest, we know that there is a fiber going in that way. So that's the basic principle. But instead of except for the fiber directions, we can also map the fiber like density, and we can also map the neuron density, shape, etc. So that's the that's the entire pipelines of diffusion MRI. So we have the brain. We first acquire images to measure the water molecules along different directions, and then we can fit a model to map the fiber pathways and also fiber properties. If we want to, and then we can do fiber tractography, fiber tracking, to piece together the local fibers in the macro levels to get the entire fiber connectome. And then we can use this basically the brain's connectivity, including all the fiber pathways. So we have the network. So we can do network analysis. We can quantify the connectivity between cortical regions to a lot of analysis. And I will mainly talk about two things. One is how we use AI to accelerate the acquisition and the reconstruction of the structural connectome. And the second one is that how can we use the most powerful MRI system and AI to map the fiber axon diameter. So actually the acquisition time we take to obtain all the images is about like 10 minutes, and this has several disadvantages. One is it's uncomfortable, especially for kids and older people, and it's also expensive because we need to spend more time, which is if we can scan more people, the fees for each patient will be lower. And sometimes it's harmful because for very young kids, we normally sedate them. So if we can do the acquisition much faster, we can avoid the sedation. And artificial intelligence is very suitable for this kind of nonlinear mapping, because like for each pixels in our brain, we have 3D signals which represents the diffusion rate along different directions. So if we do the modeling, this model is a very nonlinear model. So we can use artificial intelligence instead of using conventional methods to fit these models. So normally we use artificial intelligence like neural network to map reduce the number of acquired images to our final like matrix map. But the thing is that we cannot do it for the fiber orientation. So what we do is that we use residual learning to learn from the input images to the output images with higher SNR. Of course, I will skip some details on how we select these 6 directions and how it and all the details. But let me show you all the results. So on the most left column, that's the ground truth images we have. That's obtained by average 100 images, which takes about like let me see, 105. It's about like 10 minutes. And the second one is input image, and the most left one, that's the output of our AI system. You can see that the SNR, the noise is significantly reduced, but we can also preserve a lot of details in the brain. This is a comparison of the fiber tractography using the denoised images. And on the most left side, that's the ground truth obtained from like about 100 images. That's a 10 minutes scan. And the second one is a 7 images acquisition, which takes about only 30 seconds. And the third one, you can see that a lot of fibers are missing, which cannot represent the brain connectome of this person. And the third column, that's the deep DTI, the AI results from our neural network. We can see that we can recover a lot of broken fiber pathways. And fourth one is the BM4D, that's a denoising method. And the second row is the segmentation classification of all the fibers into 20 major white matter bundles. We can look at this fiber bundles, which is called accurate fasciculus. We can see that the deep DTI method can recover these fiber bundles. And the second thing is that if we want to quantify the connectivity strings between cortical regions, we need to first reconstruct or segment each cortical regions from another MRI image called a T1 weighted image. The acquisition of this data takes about 5 minutes. That adds up to the entire acquisition time for the reconstruction. And so we are doing another method which is very simple, because we have acquired 6 DWS already. Can we generate the T1 images out of this acquired images directly and do the brain segmentation? Yes, you can. And we published a paper earlier this year to show the possibilities. And I didn't talk a lot about the details of the neural network and the way we are doing the artificial intelligence, because you can do it in many ways because the AI technology is improving rapidly. Here, we are doing unit, GAN, and different kinds of methods, and we are doing a lot of comparisons in the paper, which you can read in our paper. But this is the result we are having. So in the most left column, that's the acquired T1 weighted images. In between, in the middle row, in the middle column, that's the input DWIs, which is input to the neural network. And the most right-hand side images is the results from a unit. We can see that the image contrast is very similar to the ground truth, and we can also preserve a lot of gray matter and white matter image contrast. Except for the high quality image regions, because the diffusion MRI has a lot of distortions and artifacts in the images, as shown in the green box, we can see that the neural network can also recover these regions back. So in addition to the image comparison, we also do the brain segmentation and then compare the segmentation results between the ground truth and the results from the unit. We can see that, I'm not sure whether you can see any difference in your naked eyes, but it's very different. It's very difficult to see the difference, because the two results are overlapping a lot. we computed the dice coefficient. We can see that the dice coefficient is mostly like above 0.9. 1 means totally overlapping. So these results are actually very good. So we are also using the segmented results to reconstruct the structural connectivity matrix on the left side. I think the human eyes cannot see any difference. I randomly chose like 100 points from these two matrices and plot the scatter plot, and we can see that most of the points are located on the 1 equal to x lines, which means that the connectivity matrix from the two methods are almost similar, almost the same. So basically, the point to conclude for this part is that we are using AI technologies to accelerate the 10 minutes scan or acquisition time to only 30 seconds. If you think that previously we can only scan one person, but now using this acquisition time, we can scan 20 patients, and this can really reduce the cost for each patient. And the second part is that I want to talk about briefly is that we can also use MRI and AI to map more complicated fiber property like the axon diameter. So I talked about the axon diameter, axon orientation, but also we can map the axon diameter and axon density. Axon diameter is important because the conductivity velocity is proportional to the axon diameter. So for the larger axon diameter, the electricity conductivity velocity is faster. So this is very important in our brain. So I will skip a lot of details. Basically, we are doing a lot of complex modeling of the diffusion MRI signal to get the axon diameter. And what we did is that we get the first whole human brain axon diameter atlas. We develop algorithm and acquire data on 20 subjects and average the results and get this map. So yellow means larger axon diameter. You can see that this is called the corticospinal tract, which is responsible for our movement and our sensing and so because it requires immediate actions, so the axon diameter is much larger than in the frontal lobe. You can see that the reddish region, which are responsible for our logic, for our thinking, for our judging. So it does not require immediate action. So the axon diameter there is much lower. Let me skip and talk about some of the AI part. The thing is that we also developed the AI technologies for the model fitting, but unlike the normally learning-based methods, our method is self-learning and physics informed. So we are using a neural network to map the input images for the model parameters. So we do not, in this time, we do not have the ground truth maps for guide the learning, but instead we are feeding the model parameters to our physics models and compute the original input images. So our learning aims to minimize the difference between the acquired and the synthesized images. If our model parameters are very accurate, and the difference should be very small and only include the noise. So
excuse me, Professor.
So let me talk.
In the essence
okay.
of time, Professor, you have about 1 minute left. Thank you.
Okay, let me talk about some of the advantages of this method because it is very fast. Because nonlinear modeling is very computationally expensive. So the model fit for one person might take 1 hour, but for our method, once it's trained, it only takes like 1 second to apply to a second person. And also, it's self-supervised. It does not acquire or require ground truth data, which might require to acquire data on patients for maybe like 10 hours. And also it's physics informed. And finally, it's feasible and accessible because it uses a well-supported AI framework like TensorFlow and PyTorch, rather than using some like self-developed software. So let me skip all these details. Basically, we are using the AI technology to improve the structure connector mapping and the microstructure mapping. And thank you for your attention.
Thank
this
you.
is
A
my
big round
team.
of applause to Professor Ki Yuan Tian. Thank you, Professor. I think we can save the question to the Q&A session. Please stay
Okay,
with us
cool.
until the end of this session. Next, we will move on to the second speaker. The topic will be Enhanced Quantitative MR Imaging, which will be delivered by Professor Huijun Chen, an associate professor at the School of Biomedical Imaging at Tsinghua University. Professor Huijun Chen holds a Bachelor of Science in Computer Science and Technology from China University of Geosciences and a PhD in Biomechanical and Biomedical Engineering from Peking University. Professor Huijun Chen's research focused on quantitative physiological imaging using MRI, particularly in the development of MR imaging methods to quantitatively characterize physiological and pathophysiological processes of human diseases in vivo. If you're ready, Professor, the floor is yours, please. Thank you.
Hi, thanks for your invitation and introduction. Can you hear me and see the PPT?
Yes, Professor, we can hear you, and you have 20 minutes. Thank you.
Yeah, thank you. Today my talk is focused on AI-enhanced quantitative MR imaging, and my focus would be in the application in cardiovascular imaging. The disease we working on is atherosclerosis. As we all know, atherosclerosis is a major healthcare challenge for the whole world. It could cause many diseases such as stroke and heart attack and many other diseases. What we focus is in carotid imaging. As we all know, it's a major risk for stroke. Currently, clinically, all the clinicians are focused on luminal stenosis. Usually, it's done by CTA, MRA, or DSA. But 30 years ago, high-resolution multi-contrast MRI has been proposed to look at other than the luminal stenosis, but also to see the vessel wall itself. As you can see here, you can in different contrast weightings in MRI, it shows different components of the plaque actually show different signals. Based on this characteristic, we can identify not only how large the plaque is, but also what components actually are in. As shown here, this is a very high risk feature. Components, we call it intraplaque hemorrhage or IPH. And this is the case for, this is a three case to show why vessel wall imaging is more important than luminal stenosis alone. All those three cases actually, you can see it's different stenosis. This is a mild stenosis, medial stenosis, and very severe stenosis. But when you see vessel wall, you can observe very large plaque, as I show here, in this with only merely stenosis cases. This may indicate if we only focus on stenosis, we may left a lot of patients actually with high risk. then let's focus on when we do vessel wall MR imaging, what we need to do. So basically, we need to scan multi-contrast MRI, and we need to post-processing them, and we need to generate a model such as like this. We can know the luminal, what luminal looks like, and also what the vessel wall looks like, and all the components inside it. But it faces several challenges. The first challenge is the scan time. Usually it would be more than 15 minutes and even longer if you want to acquire a lot of contrast weighting in MR. And the coverage is also very limited. It's only 40 millimeter. As long as we do the post-processing is also very long. Also, although with some semi-automatic algorithm and method, the review and processing time usually is more than 20 minutes. And another thing is that when we do carotid imaging, we know we want to prevent stroke, which means we also need to acquire brain imaging, especially perfusion, brain perfusion, to identify whether this stenosis or this atherosclerosis actually affect the brain. So currently there is no such fast imaging method to do so. So our group actually focus on this area, and we propose intelligent vessel wall imaging and processing method, including imaging, image reconstruction, and image processing. First, I will briefly introduce some of my sequence work. This is no AI related, but this sequence actually can provide more information than traditional MR sequence, and it could facilitate the AI usage in this area. So this method, we call it goal snap method. The difference from traditional MR imaging is in this one sequence, we can get multiple weighted images, and we finally can generate quantitative mapping from it. This method is for T1 mapping, and we also developed something very similar, but we add more weightings and quantitative imaging. This is called simple method. We not only can quantify T1, we also can quantify T2. And this one is just published last year. We also added T1, T2, and T2 star mapping. As you can see here, this method actually compared to traditional multi-contrast imaging, we're trying to limited the scan time into 5 minutes, and we need only one scan. And one thing I want to emphasize is because this is one scan, we can get a multi-contrast imaging. This is quite easy for AI method to generate segmentation or composition detection methods, because they are all registered, and 1 pixels inside this image actually have multiple informations. And this is an example. You can see images derived from our method. This is a simple. We can get MRA, and we can get T1 weighted, T2 weighted, and PD weighted. And also we can provide quantitative imaging such as T1 and T2 map. But this method still suffers some problem. One problem is the recount time is pretty long. So we use AI to facilitate to enhance the imaging reconstruction. The first method I want to talk about is this method, we call it Dente. Because we still using the MR reconstruction, the MR reconstruction scheme, but because this is the quantitative imaging, so we actually replace the fitting after we got the weighted image, we need to fit to get a quantitative imaging. We replace the fitting method using UNet. it's quite a traditional network, but the innovation of this method is after this fitting, we actually using the physical model to generate from the fitting result to generate a weighted image, and we use this generated weighting image to optimize the traditional MR reconstruction scheme. So this method actually have a pretty good performance, such as we can further reduce the scan time and significantly reduce the recon time plus the fitting time. And our accuracy of T1 quantification actually can improve. And this is the result in brain imaging, and you can see our method actually outperform all other MR recon method. And this is the test result of carotid plaque. And you can see we can generate a very similar T1 mapping image compared to other traditional image. Another research I want to talk about is we just published a paper in medical image analysis. This method actually, I think it's a fundamental change to a convolutional neural network. Because we propose a plug and play plug, we call it a Fourier convolution block, FCB. Because the convolution we do in space domain, the receptive field RF actually is usually is small. Usually you use 3+3. But if we do this convolution in Fourier domain, and we can have a global RF, this is the illustration of the method. One thing we want to see is our proposed FCB actually can be used in all the convolution networks, and it can improve the performance for those CNN architectures. As you can see, this other than the image and also the quantitative metrics also can be improved. And we also visualize what this convolution kernel actually do. As you can see, if you use traditional UNet, the convolution is done in space domain, and all the ranks of the trained convolution actually can look like here. But in our Fourier domain UNet, and you can see actually our method actually have a global view of the whole image. And we also computed the effective RF, and different from UNet, our FUNet actually have a pretty similar to the PSF of the sampling. And because of the sequence and the reconstruction, and we also can develop AI enhanced image processing. And this is one example which we utilize multiple weightings of this kind of sequence, and using it to segment the vessel wall of carotid artery. And we also win a challenge, which is SMRA and Mikai Grant Challenge in 2021, the second place, to segment the lumen and the vessel wall. We are the after this challenge, we are the organizers of this challenge also for this year. And we, other than the carotid imaging, we currently are focused on intracranial vessel wall. And for such kind of AI enhanced processing, we can segment the intracranial vessel wall pretty well also. And the last thing I want to talk about is the brain imaging part. Different from Professor Tian's previous work, we focus on perfusion imaging, which is blood flow, what we call it the blood perfusion. of the brain, which is also important for brain function. So the sequence we based is a special sequence in MRI. We call it fingerprint. This sequence, let me briefly introduce this sequence. So this sequence is basically randomize the acquisition procedure using randomized such as flip-and-go or TE or TR. So because of that, the generated signal actually have a unique feature for different parameters, such as T1, T2. And in this ASL MR fingerprint, that's also including the CBF or other things. So though traditionally for this kind of sequence, they use a method called dictionary matching, which is a pattern recognition method to reconstruct the quantitative imaging. What we develop is we call it a deep MARS method. This is a very simple method because this is a fully connected model. But we generally we replace that. We replace the dictionary matching using our using this fully connected model, and you can see as for the accuracy in simulation, our method actually outperform the traditional method, and this is actually this is the real image. We actually test the reproducibility of the quantification, and similarly, our deep MARS method actually can outperform the traditional dictionary matching method a lot. And this is the patient scan. This is the patient with Moyamoya disease. And with the dictionary matching, you can see no matter the CBF and the BAT calculated by the dictionary matching, you can see a lot of noise point here. And this is caused by what we call it fitting failure. But we use deep MARS, you can see there's no such noise point. And more importantly, all the hyperperfusion part, all the hyper or hypoperfusion of the patients are very similar to the dictionary matching without the noise. So that's very promising results. So as a conclusion, today my talk covers all those three parts. First, we propose this large coverage, multi-contrast, and quantitative imaging method. And actually, it can be acquired with one scan with a few minutes. Let's include this new sequence design, and we also can using AI to enhance the image reconstruction to make it more useful in clinic. And also we also develop the fast imaging analysis facilitated by our sequence and our recon. But it's also very good for AI post-processing. And we also develop a method for fast imaging, fast brain perfusion imaging using AI. That's all my talk. Thanks.
Thank you, Professor. Big round of applause, please. Thank you. We will save the questions to the Q&A. Professor, please stay until the end of this session. So for the next speaker, we have here in person, Mr. Fang Zhou Liao. He will be delivering the third topic on the introduction to China's radiology AI utilization. Mr. Fang Zhou Liao received his degree in chemical biology and PhD in biomedical engineering from Tsinghua University, Beijing, China, in 2013 and 2018. He is currently the chief AI scientist with Sukun Network Technology Ltd, Beijing. The product he developed currently runs on 4,000 medical institutions globally. So please, if you're ready, Mr. Fang Zhou Liao, I will have handed over the floor to you, please.
Thank you. This is my second time in Bali, and this is a beautiful place. And I don't even know Tsinghua University has a campus in Bali. I spent near 10 years in Tsinghua University, so it's a kind of a going home this time. And thanks for the invitation from the colleagues in Tsinghua Southeast East. So as introduced, I worked in a radiology AI company, and I want to show you what is our job and what's our purpose. And the first thing is I will show you the overview of our company. And the second thing is introduction of our 2 killer apps. And I want to briefly tell you the evolution of the doctor's attitude we faced. One question, I think this talk should be 30 minutes. Yeah.
Yes, it's 30 minutes. Yeah.
So as introduced, our company, the Shukuntech, is now the biggest radiology AI company, or you can call it medical AI company in China. Our solution has been deployed to over 4,000 medical institutions, including hospitals in China mainland, Hong Kong, Japan, Singapore. Oh, sorry. And we processed many. I can't count how many zeros patients, and only on the online API we provided for the customers, there are 40,000 patients per day that is processed online. This is the paper we collaborated with top-tier universities or top-tier hospitals in China. And this is our portfolio. It is a very big portfolio. I can't go through it today because if I spend 1 minute for one product, 30 minutes is not enough for me. Yeah, we have nowadays 14 NMPA-approved products. NMPA-approved means the China's FDA-approved medical AI products. And we have 4 CE-approved products and 2 FDA-approved. And this is our current global customers. So I would like to introduce you the 2 of our best sellers and tell you the basic logic, why it sells so good, why so many hospitals want to use these things. So I see there is a radiologist there. I want to know whether there are more radiologists here. Oh, 2. Okay, thank you. And how many doctors here? Sorry, how many doctors here? Wow, so many. Nice to meet you. So let me briefly introduce what is a radiologist's job in terms of a cardiology task. So the first thing is, for of course, scanning, and the CT scan the image push to PACS and send the record to HIS. So the radiologist must remember who is his name, what is his ID, and write down on the paper, and goes to the workstation, GPS workstation, G workstation, Philips workstation, and pull the image from the PACS, and then start his reconstruction job. It may cost about 50 minutes. This is a video I draw from YouTube. You can briefly go through it. Well, it's mainly click, and click. Yeah, you must click for 15 minutes to finish a reconstruction of a coronary artery. and prepare for the slides for the next doctor. And then he pushed these things to the PACS again. And the doctor two read these images processed by Dr. 1 and start to write down diagnosis. And then he must push those images to the printer and write down the diagnosis report. So the time cost is around 15 seconds in this. Sorry. It usually costs 15 seconds in the step 1 and about 10 minutes in step 2. But the overall time is much more than this because Dr. 1 has a working list, Dr. 2 has a working list. You must waiting for the Dr. 1 finish the list 1 and then Dr. 2 start his list. So that's why you have to get the report after 3 days or even 4 days. And the workstation is quite expensive actually. So this is the workflow we proposed. We have a central server in the hospital, and the CT image pushed directly to our server. And our server, firstly, it identifies this is a coronary CT scan by himself. Yeah, you don't have to tell him this is a coronary. And he will start the computation immediately. And he will do the reconstruction, diagnosis, and write the reports for you. And the doctor, you just need one doctor with a very poor performance PC. It can be a Windows XP, and it can be an IE Explorer, just access to our AI server. And you have a powerful, fully functional workstation. You can interactive and to modify all the wrong results here, and write reports. And the server will prepare the printing materials automatically for you. You don't have to select which slides. He will remember your preference, and so the workflow here would be very fast, and it dramatically reduce the time cost and the money cost. Just to give you a brief introduction of the AI process. The first step is we do segmentation, and from the segmentation we do vessel naming. You see those colors with different, the vessel with different colors, different vessels. And with these vessels, we straighten these vessels, do segmentation. We segment all the volumes, all the plaques, and these are then remapped to the original image. These different colors means different plaques. And finally, we will start to use a mechanical engine to calculate the fluid dynamics, to calculate the CT-FFR value. And finally, since we know where the plaque is, we can automatically choose the best layer and the stenosis rates, and automatically outputs the reports. So what is the effect? So these are very renowned hospitals in China. After adopting the AI, you can see a dramatic increase of coronary scanning. Considering the high value of CT coronary scanning is about 1,000 yuan or $150 per case, it is a very large annual income. After 1 or 2 years, this AI system can win the money back. And for the patients, it significantly reduced the report latency. You don't have to wait for 4 days, 3 days. You just have to wait for 1 day. And for the doctor, for the hospital, you don't have to use 3 steps. You only have 1 step to write a coronary report. And another finding is that we found this AI algorithm so robust that it's lowered the device requirements. Traditionally, we think we need a 128-row CT to produce a coronary CT, but now in our experiments, 64-row CT is enough for this AI to reconstruct a very beautiful coronary system. And while the doctors doesn't need to move from his computer to his workstation, from his computer to his workstation. He just stay at his computer and no need to touch the workstation anymore. There are the papers we published relating to this product. And how about this product's potential in Indonesia? Just that Sir introduced, I go to the Kementerian website and grabbed these values. Wow. And what surprised me the most is there is only 840 medical physicists in Indonesia, which is nearly 100 times fewer than Chinese medical physicists. And comparably, the doctors is not so smaller, right? Considering the population difference. So I assume the coronary diagnosis or coronary CT scan is not fully conducted in Indonesia. We have many experience that introduce this advanced technique to some lower level hospitals and expand this technology. I think it's very helpful. The second story is the lung CT. If you are familiar with the radiologist AI, this is a very, very, very hot topic. There are hundreds of companies that is working on this scenario. So briefly, what is the doctors doing for these images? The diagnosis, the lung nodule, pneumonia, emphysema, and lymph node. So what is so important? Why everybody is doing this? The reason is simple. This is very, very, very big amounts. This is the most commonly used scanning in China. In a big hospital, I've seen over 1,000 per case for one hospital per day, and one radiologist must read over 100 cases per day. And this is very important for early lung cancer screening, and as you know, lung cancer is a very dangerous disease. So what is the pinpoint? First is the amount is so big, and second, the object is so tiny. You have to look for the nodules that is bigger than 3 millimeters, which is 4 pixels, which is very, very tiny, and very easy to miss if you don't concentrate. So what we provide is a very fast and very accurate and fully functional product. How to say? So it is very fast because from the scanning to the report, it only costs 1 minute. From the data transporting, we start the calculation. Calculation only costs about 30 minutes, 30 seconds. It's very fast. And it achieved a very high recall. It goes to 92% and with a pretty high precision. Since it's a screening product, so for the preference, we prefer a higher recall instead of a higher precision. And actually, those we call the false positive here are mostly they are acceptable. You may read some papers that claims they have 99%. Well, they are not trustworthy. Yeah, every industry proved products. If they achieve such a number, it's already a very, very good, and its performance is much better than a young radiologist. And yeah, so the second thing, the first thing is we provide automatic reports with figure and structure table. And we can do automatic follow-up, measuring the nodule growth rates. And if it grows bigger, you want to do surgery, we also provide precise artery segmentation, lung segments for you to aid the surgery planning. And on the lung CT, we can also diagnose fracture, but fracture is frequently missed or doesn't include it in the report because it's very hard to write. So we provide this advanced fracture module. It can diagnose this fracture on basically every bone you can see in the lung CT. And we provide an advanced volume rendering engine. It's not in workstation, it's in website, online. You can use it on your Windows XP and Internet Explorer. And we do precise rib counting and do some advanced visualization so that the doctors can easily identify the lesion spots and check the results. And what's more, there are another two things that you can diagnose from the lung CT. The first thing is calcium score, which is responsible for the artery diseases. If somebody have a high calcium score, it tends to be coronary disease. Usually this does not include in the lung CT report, but we also provide this thing so that it's very, very useful for the large population screening projects. And the second thing is the osteoporosis, namely the bone density. Yeah, for the older man, the bone is too weak. We can quantify how weak the bone is. So the results tend to be very exciting. This is an example hospital that adopts our AI. So the number of patients that stays in the hospital grows very fast. And the annual income brought by these surgery patients also grows very fast. And most importantly, they conduct a large-scale screening project in that city. And in that project, in last year, in 2023, we screened 200 early stage lung cancer patients that can be treated very well. as you know, the lung cancer is very dangerous. If you feel uncomfortable and you go to lung CT, it turns out to be a late stage, usually. But in this screening, it's usually early stage. And this is a collaboration with Meinian, which is the biggest health check institution in China. We got some statistics from the region, from the age, from the gender, or we found some interesting phenomena that about the lung nodule. Yeah. So they are the two of the products I show you, but we have lots of products. Indeed, we have the biggest cerebral or stroke products family, CTA, CTP, NCCT, and aneurysm. Basically, we can diagnose everything about stroke. And we also have an ultrasound device. Yeah, it is a projector that is installed above your screen. And it can project green lights on your screen and showing where the nodule is. Yeah, you see there is a flashing green bounding box. And our next stage is insert this AI into our own ultrasound device. So this will be a built-in AI ultrasound device. If you compare Shukun with other international players or in this domain, you will find we have the richest portfolio from heart, brain, chest, abdomen, and bone. Oh, sorry. So the final part, I want to show you some, share with you some discussions that we face some attitude from doctors. The first thing, the first one is, wow, AI is so powerful, I will be replaced. I will get fired. And the second one say, AI is so stupid, it makes so many mistakes. It's useless. Well, what I want to say is both of them is not very correct. It's correct to some corners. Yeah. Nowadays, Chinese doctors cannot leave AI. Yeah, frankly speaking, they cannot leave AI. There is one day about 8 o'clock, I was called up by Anzhen Hospital doctor, which is the largest cardiology hospital in China. Said, your server crashed. I cannot work. Come now. And I didn't brush my teeth and just lie down on my back and rush to the hospital. And the hospital already lines up a very long line that waiting for the coronary CT scan. Since the doctor refused to work, they refused to do the post-processing or reconstruction like before. They are waiting for me to fix the machine. Fortunately, yeah, I fixed that machine very quickly. Yeah, this is a story that I want to share with you, that the doctors cannot go back. Once they get, they know, oh, the AI is useful. It can save my time. It can't go back. Yeah, there are many examples that we give the AI for trial for about 1 month, and after 1 month, we will want to take the trial machine to another hospital, and the doctors will say to their leaders, say, buy it, we need it. Yeah, it's very common. But as another thing, another stage is, can it really replace doctors? No. Yeah, it have very strong advantages. They can faithfully process lots of cases with low price, but it's not mature yet. It relies on doctor to work. So why is that? Let me show you some examples that are true example from our own products. This is a lung CT or tumor diagnosis part. This is a normal tissue in mediastinum, and the AI think it is a tumor because it is round, because it's rounder than other guys. This is aorta. There is a yellow box here. This is aorta, and the AI said this is a tumor. This is lymph node. AI said it is tumor. This is lower part of your lung. I forget the English name. This is a protruding bone into the lung. And this is a vessel with strange shape. So as you can see, the AI performs very strangely. On average, it performs very well. Recall, precision, anything else, it is higher than even senior doctors. But it makes silly, very, very silly mistakes occasionally. Yeah, it happens for every AI product around the world. And for us, what we can do is suppress the rate of these stupid things. Now we have suppressed it to 10,000 cases per one. Yeah, one per 10,000. It is an extraordinary work. But as you can see, we have 40,000 cases online per day. Oh, sorry. So actually, we still receive some sort of these stupid things day by day. I will quickly show you what is our products looks like. This is our cerebral dock products. Wait a minute. Because the data is transporting from China to here, this is an online service. My laptop is only a front end. All the calculation, all the data is stored in server in China. And as you can see, this interface is no different with a workstation. And you can do everything workstation can do on this interface. But sorry, the internet here is not very quick. Usually in China, if we have a server in Indonesia, it should be very smooth. And it can do a vessel task, and it detects the aneurysm here. If you want to see the aneurysm in more detail, we can provide you with a zoom-in view of the aneurysm. And we have lots of parameters, the long axis, the short axis, volume, area, angle, many other measured parameters about this aneurysm.
Excuse me, Mr. Fangio.
Yeah, yes, sorry, yeah.
It's time to...
So give me another 1 minute. So this slide is meant for another guy that cannot come, yeah. So anyone from the pathology lab? Oh, no one from the pathology lab. So this is also a Chinese company called Thorough Insight. Their job is doing pathology diagnosis. So what they provide is a very automatic and a very integrated solution. They sell you the machine and the software at once. It is a total solution for the pathology lab. And it covers almost all the cases pathology lab will face. Yeah, if you are interested with this, you can contact with me. Okay, thank you.
Thank you. A very round of applause to Mr. Franjolio. Yeah. Please come sit with me. And our last speaker will be delivering the topic of AI in action, streamlining healthcare systems for better outcomes. Presented by Bapak Isaac Jenny. He is an advisor to the Ministry of Health in Indonesia. He is helping to streamline the country's vaccination digital platform and healthcare digitalization efforts. In his role at the ministry, he has architected and built healthcare platforms, designs, and implemented these digital processes to eliminate costly user roadblocks and identified efficiencies in the system. Bapak Isaac Jenny will be presenting online. Bapak Isaac, are you ready? You have 20 minutes, please.
Okay, thank you. Hello, everyone. Good day. Sorry, I cannot join in person for this event. Suddenly, I have a ad hoc meeting, very important, so I missed the beautiful Bali. Okay, let's start. Can you go to the next slide? Slide belum.
Operator, please help.
Okay, so the healthcare industry faces an overwhelming challenges. This is the challenges, too much data. Yeah. Imagine a hospital with 500 beds every year. Yeah. It generates around 5 petabytes of data. That's an equivalent of millions of books filled with the critical patient information. Yet, this sheer volume becomes a burden. Not only it's difficult to store and manage, but much of it discarded. The data is discarded because it's nearly impossible to analyze such vast amount of data manually. As a result, healthcare professionals are forced to focus only on snapshot data. This is what happened. Only a snapshot data, just a moment in time to diagnose symptoms, frequently missing the bigger picture. This is, I think, where the AI steps in. AI has the capability of process massive data sets, spotting patterns and trends that humans simply cannot understand. By analyzing vast amount of data in real time, AI can help doctors move beyond the limits of snapshot information, enabling more accurate diagnosis and proactive treatment plans. Hello, I think.
Ada yang bocor, tolong di mute.
Yeah, I think somebody ini ada yang bocor ya. So, AI is more than technological advancement. It's a game changer that promises to make healthcare more efficient, effective, and equitable for everyone. By harnessing the power of AI, we can move beyond today's challenges and build systems that work smarter and serve better. Today, let's explore how AI can help us by being the active partner shaping operational healthcare. Next slide, please. Slide operation, next slide. Oh yeah. As we look at today's healthcare system, it is clear that there are critical challenges we must address to improve outcomes and efficiency. One of the major hurdles is rising costs. Global healthcare spending reached a staggering $8.3 trillion in 2020. And what's more concerning, that's up to 40% of these costs are costs of administration. This means that resources are being diverted from patient care, putting financial strain on both the healthcare system and patients. Then there is an issue also, a workforce shortage and burnout. By 2030, it is projected that the global healthcare sector will face a shortfall of 18 million professionals. Today, more than half of the healthcare workers report burnout, further adding the stress on the system. This leaves us with fewer professionals to care for an increasing number of patients. Indonesia is having the same problem as well. You know, patients waiting hours for doctors, creating additional stress to the already stressful patients. Inefficiencies and diagnosis and treatment are another pressing concern also. Diagnostic error affect 12 million people each year in the United States alone. I don't know what happened in Indonesia. We don't have the data, by the way. And the rate of misdiagnosed for serious condition like sepsis is as high as 30%. These inefficiencies not only lead to the poor patient outcomes, I think, but also drive up costs as conditions are either undiagnosed or improperly treated. And there are also an issue on fragmented and unstructured patient data. About 80% of healthcare data remain unstructured, making it difficult to analyze and draw valuable insight for patient care. Although in Ministry of Health, we are actively working to solve the challenge by implementing the SL7 framework to restructure healthcare data with Satu Sehat implementation. This effort will enable us to standardize how data is captured and shared, making it easier to integrate and improve patient outcomes. Next slide, please. Okay, there are several examples. Yeah. The NSS collaboration with Google DeepMind focus on using AI to detect acute kidney injury, AKI, earlier and more accurately. The project harness AI to analyze patient data in real time. This is the Google project, which gave doctor a crucial 80 hours head start in identifying life-threatening condition. This early warning system was a breakthrough because it's allowed for faster intervention, eventually improving patient outcomes. Compared to traditional method where diagnosis really relied heavily on manual data review and delayed detection, the AI-powered approach provided 30% faster diagnosis. I have another example in South Korea, actually. I was there last year. Every citizen in South Korea is required to undergo the TBC screening every 2 years, ensuring early detection and treatment. In some of the center, we went there. During this process, some random thorax images are sent to both doctor and AI for analysis. So the AI is continuously trained by comparing its diagnosis to made by human doctors. If the AI diagnosis differ from the doctor, the image is automatically sent to another doctor for further review. This system, this Korea system back then is able to helping to build a massive large-scale diagnostic problem by combining expertise with AI, doctor expertise with AI ability to quickly analyze a vast amount of data. It's not only improve diagnosis accuracy, but also enhance its efficiency for the screening process, ensuring the potential cases of TBC are caught early. So next slide. This is actually the slide that I want to give the focus. Yeah, there is another example on operational AI in the US. Yeah, a process known as a digital scribe is becoming increasingly common, and is redefining how doctors manage their administrative workloads. Traditionally, during the consultation, after the consultation actually, doctors spend significant time documenting the visit, entering patient notes, coding the diagnosis and treatment plan according to ICD codes. The standardized time used for billing and medical records. This can be very time consuming, often taking away valuable times that could be spent on patient to care. Digital scribe use AI in US, use AI to automatically listen to the conversation between doctor and patient during the consultation. Basically, the AI is listening. The system then analyze the conversation in real time, identifying key details like a patient symptom, diagnosis, and treatment plan. Once the visit is over, the AI is generated a structured summary of the consultation, which is include critical information like medical history, prescription, and follow-up plans, something like that. Even more impressively, the AI convert this summary into structured data aligned with ICD-9 or ICD-10 coding system, ready to entry into the patient EHR for billing purposes. If you see this one, the big benefit for doctor for this system dramatically reduce their administrative burden. Instead of spending hours and hours in putting patient data and ensuring that medical codes are accurate, doctor can focus more on what they do best, treating patients, caring for the patients. By automating these administrative tasks, digital scribe frees up valuable time, reduce human error, and help prevent burnout, which is growing problem among healthcare professionals, like in the first slide. This technology doesn't replace the doctor, but rather acts as an efficient assistant, ensuring the doctor have more time to deliver high quality care while the back-end paperwork was taken care. In Indonesia, the inefficiencies related to coding patient diagnosis go beyond just time wasted during consultation. In some of our Ministry of Health hospitals, dedicated coders are hired to convert patient notes into ICD-9 and ICD-10 codes, which is both labor intensive and costly and error prone. In other hospitals, doctor may ask nurses to handle some of these tasks, including the data entry, leading to further delay or potential inaccuracies. There are even cases where the doctor manually select ICD codes during patient examination, a process that significantly slows down patient care and wastes time, particularly during critical moment like consultation. Actually, this one, it's happening to me myself. While the doctor treating me, consulting with me, the doctor actually selecting the ICD codes in front of me. So this inefficiency has far-reaching consequences actually. Doctor and nurses are pulled away from the patient care to focus on administrative tasks, leading the slower service and longer wait time for patients. The manual coding process also prone for errors, which can lead to incorrect billing and delays for submitting medical record. One major benefit of AI in this context is that ICD-9 and ICD-10 codes can be submitted directly to Satu Sehat and BPJS. BPJS is our Indonesian insurance system. As soon as the data is generated, this seamless integration allows hospital to receive reimbursement from BPJS faster, improving cash flow and ensuring that hospital are reimbursed accurately and promptly. Eventually, by leveraging AI to automate and streamline the coding process, hospital can save time, reduce operational costs, and increase efficiency. This is not only benefit patient for speeding up care, but also is a win-win for everyone involved, from healthcare provider to patient to administrator. Next slide. Today, we stand at the exciting frontier of integrating AI into our healthcare system. So let's see the challenges. Data privacy and security are paramount as we move forward. With AI processing large volume of patient data, ensuring compliance with global standards like SIPAA, which is we don't have at this time, is essential. Indonesian new privacy law will also play a very crucial role here, making sure that any AI system used in healthcare safeguard patient information, providing transparency and how data is used. Another critical consideration is bias and fairness in AI. Bias and fairness. AI systems rely on a large data set to make decisions, and these data sets are not diverse, most of it. The AI can unintentionally develop biases, making inaccurate and unequal diagnosis. This is where government body like BGSI, and Binomika can play a key role. In Indonesia, for example, with over 1,700 tribes, each having its unique DNA structure and medical needs, it is imperative for us to ensure our AI system are trained on diverse data set. This includes not only genetic data, but also anonymous patient data that reflects the full spectrum of our population. The way different tribes react to the treatment, medication, or even environmental factors must be considered. With BGSI expertise, we need to ensure that AI models are fair and accurate for all Indonesians, so it can improving the health outcomes across the every region and country. On the regulatory and legal perspective, we also face important decision. AI is evolving rapidly, like the first presentation. And while the Ministry of Health play a crucial role, we in the Ministry of Health may not be fully equipped to handle the complexity of AI impact. This is why we need to actively collaborate with other bodies like CONICA or universities, ensuring that we create regulation that balance innovation with safety. This regulation should not be overly restrictive, as they would stifle AI research and development. Instead, we need the regulation that provides certainty for AI researchers while still protecting the patient safety. This will help build a healthy ecosystem for AI development in healthcare, one that encourages innovation while keeping the well-being of the patient front and center. We did some this also with the 3 hospitals working with the AI company in from the world, doing the critical clinical trial in the some of our hospitals. This is already ongoing process. Then we need to make sure we protect everything. Yeah. Finally, we must talk also about the transparency and accountability. It is crucial that the AI system we deploy are not seen as black boxes, where decisions are made without clear reasoning. As we know already, after you hear from the first to now, AI is not magic. It's a set algorithm driven by data. We need to design the process that ensure we understand exactly how AI reaches its conclusions. By ensuring transparency, we can track and audit AI decisions, allowing us to provide feedback and make improvement. In summary, the future of AI in healthcare is exciting, and while we must address these challenges, it is clear that we have the tools and expertise to do so by ensuring strong data privacy, minimizing bias, working closely with regulatory bodies, and prioritizing transparency. We can build a healthcare system that not only leverage AI potential, but also enhance trust, safety, and efficiency. Next slide. As we move from vision to reality in integrating AI into our operational healthcare system, there is also still a lot of groundwork to be done. First, collaboration is key. We need to engage stakeholders across government, healthcare professional, and technology companies to create unified approach. Just as Europe has done with its Health Data Space Initiative, we need to foster partnership to ensure seamless integration of AI into healthcare. The Ministry of Health already started with Satu Sehat as fundamental data infrastructure for the healthcare, and we can move forward from the Satu Sehat into the more a much better result. Second, we must educate our healthcare workers, equip them with the skills to effectively use AI tools. Upskilling is essential for ensuring that doctors, nurses, and other staff can confidently work alongside AI, making the most of its capabilities. Finally, the third one, we must invest in building AI-ready environment. This means integrating EHR, adopting cloud computing, and preparing for our infrastructure for AI. For example, Japan investment of $140 million for 2027 in AI healthcare is a great example of that. We need to forward-thinking investment that we can learn from. Yeah. Again, investment in Satu Sehat at this today is a great way to start all of this. Next slide. Okay, that's all. So basically, just some closing. As we stand at the intersection of technology and healthcare, it's important to remind ourselves that AI is not here to replace healthcare professional. AI will take over healthcare professional role, at least, I think, not in our lifetime, okay? Instead, it is a tool designed to make your work more efficient, accurate, and impactful. By automating administrative tasks, streamlining diagnosis processes, and assisting with data management, AI frees the doctor and the professional, healthcare professional from the burden of paperwork and allow you to focus what truly matters, caring for your patient. AI is not competitor, but a partner, I think, helping us achieve more in less time with greater precision and less stress. It empowers healthcare professional to excel in the profession while giving us back precious time to enjoy life outside of work. So let's build the future where AI enhance healthcare for all without compromising the human touch that make us truly exceptional. Thank you, everyone. Enjoy the beautiful Bali. God bless you all.
Thank you, Bapak Izan. A big round of applause. We are commencing our Q&A session. I believe we have about 10 minutes, yes, because we are starting 10 minutes late, yeah. So I will ask the operator to spotlight all the 3 speakers onto our screen. Can we do that? And then, yes, for Q&A session, yes? Yeah. Okay, so I will invite the participants. If you have any questions, feel free to ask to our speakers. Yes, first one, next up.
Thank you for all the excellent presentations. My name is Nur Huda. I am a radiologist from Sarjito Hospital and Gadjah Mada University in Yogyakarta. So I have 2 questions for all of the speakers. The first question is about the role of radiology in AI development. So based on your experience, what has been the role of radiologists in this process? And also in the future, what will be the roles of doctors and radiologists in assisting in AI development in this field? And the second question is about the implementation or generalizability of AI model. So as we know, AI is trained on well-organized data or maybe clean data, but it is very different from real-world cases where the data is often messy.
Professor Ki Yuan Tian and also Professor Hui Jun Chen.
I think we should never forget that the role of the AI, it's basically a form of automation. There's no difference of AI comparing to a car, a machine that can do stuff for humans. So I think that for me, that's its essence. So it's just one kind of automation. If you think of the industrial revolution, it's always like a revolution of the new energy, like the steam, like the electricity, like whatever, followed by a new generation of automation methods. After the the first industrial revolution, we have all the kinds of machines which can make stuff for us. After electricity, we have all the stuff. So for the AI, that's one form of automation. So I think the problem for us now is the new energy. I think that's the main problems for the use of AI in everyday life. So my point is that it's helping humans. So for radiologists, I think all the AI tools are helping radiologists. So we should do like a human-centered AI. So I think the role of the radiologist is to like help the AI scientists to develop the tools, because like we do not have we have ground truths, but I think the most important ground truths for the AI is basically whether it can do work normally done by a very experienced radiologist. So, but that should be judged by the radiologists. So, I also think that the radiologists should provide a lot of rules, a lot of principles for the AI technologies. like in terms of accuracy, in terms of privacy, in terms of everything. So still we need the radiologists to for and ask them for a lot of help. So that's my answers to the first question. Is there a second question?
Yes, the second question would be how to bridge the gap, yeah, because the data for AI usually is not as messy as real world evidence, the cases that the radiologists face in the daily practice.
Yeah, I think technology-wise, I think we are doing a lot of like generalized AI, like basically the AI for general tasks, such as ChatGPT, those kind of things. So it's not like for specialized thing. So I understand that because I got my training in the radiology department. So uh, like I think like Fangzhou talked a lot about the like diagnosis methods their company develops. But I think for me, I think another difficult part for in the radiology department is for the data acquisition, like which data should we acquire, which sequence, which contrast, and whether the acquired images are okay enough, or should we acquire another set of images, and whether we can automate the scanning process, like choosing the ROI, and maybe we should acquire higher resolution for the tumor regions. So that's the decision making. So that's the more difficult part for the radiology process. It's not just about the diagnosis. So I think that's my question. I think technology-wise, we should develop more like a general and more multitasking AI technologies. And of course, like then we need a much more complex data, like and a much smarter training ways and much smarter AI technology. And in general, like for medical AI, there is a lack of data comparing to natural images or normal computer vision tasks. So I think that's calling for the collaboration of all the hospitals in a country and even all the hospitals in the world to find a way to share the data and use all the data uh, uh, possibly can be acquired by all of us to train a network like ChatGPT that can serve all the patients and for improve the healthcare.
Thank you,
Yeah,
Professor.
Actually, Professor Tian has I totally agree with Professor Tian. From our work, you can see actually AI is not only for the interpretation of the image itself, it also can help to produce the image automatically generated image or even the scan process, even the patient, how you should manage to the patient. And for another level, we didn't mention for this communication is like, currently a lot of AI work actually can predict the outcomes and also can optimize the clinical procedures after the diagnosis of the radiologist. So that's also for the it's kind of assistant to the physicians to do operations or to to schedule to make plans for the treatment of the patients. That's also AI currently is also helping with that. So I think AI is infiltrate the whole process of our healthcare system. And I think for not only for radiologists, I think all the doctors should embrace this technology and I would say embrace this new era. But our doctors and I actually is also trained in Department of Radiology in University of Washington. I totally understand current, the gap or some worries from the radiologists, what we should do. But I would say is like we do need to, learn how to use it, and we do need to, trying to enhance our ability to use AI, but also to enhance our ability to improve the AI method itself. That would be, in clinical image, our clinical data is kind of a very unique data because, especially for some rare diseases, in nature, there's no much data, right? So I think radiologists or other doctors still have their position, but that's just for the people actually can embrace this technology. I think that's my that's my comments on that. Hopefully, it's helpful.
Thank you, Professor.
Thanks.
Do we still have some time? No? So, yes, I guess I think that concludes our session for today. The key takeaways is, whether you like it or not, AI is here, and we need to decide how we move forward with AI and use that to aid our healthcare systems. I thank our 4 distinguished speakers and also all the participants for their active participation. Thank you.
Thank you. Let's give a round of applause for Dr. Donna, Arlinda, and it was a very tight session. I do understand, but again, we are trying to be punctual. So, boleh kembali ke tempat masing-masing, sir. Thank you very much for speaking on a topic where I rarely seem interested. Meaning in his technology, but I was just sitting there and watching all his images and going, wow, we have come this far. All right, so it's time for lunch. It is time for lunch. We have one more session. This is a very important announcement that I will have to convey to you right now. So ladies and gentlemen, if you would please bear with me. VIP speakers and moderators, lunch will be held at Coco Lounge. Coco Lounge is in front of the auditorium. And for the participants, lunch will also be on this floor, lantai 3 juga, but at the tech incubator. I think it's further up there, yeah? Betul? Yeah. So you go straight, and I think it's a bit to the right after the staircase. So yeah, have sumptuous lunch. Maybe even chat with each other for questions that couldn't be surfaced here on the talk show, on the panel, I mean. And I'll see you in 45 minutes from now. I'm so sorry, but it's 45 minutes from now. So I'll see you back here at 1:43, 1:44. Thank you. Selamat makan. Bapak dan Ibu yang kami hormati, kami mengundang Anda untuk kembali ke awan auditorium karena sesi ketiga akan segera kita mulai. Sesi ini adalah sesi yang terakhir. Ladies and gentlemen, we'd like to invite you back into the awan auditorium as our third session, our final session for today, will soon commence. Thank you very much. Bapak dan Ibu yang kami hormati, bagi Anda yang mungkin masih berada di area foyer, kembali kami mengundang agar Anda dapat memasuki ruangan. Kita akan segera mengikuti sesi terakhir. Our third session for today will soon commence. So ladies and gentlemen, if you are within the foyer or auditorium area, we would like for you to make your way towards the auditorium. And please be seated as we will commence our third and final session for today. Thank you very much. Ladies and gentlemen, we would also like to gently remind you to ensure that your phones are on silent mode. Mohon alat hubung handphone Anda dapat berada pada mode silent karena sebentar lagi acara akan kami mulai. Thank you. Selamat siang kembali. I hope you had a sumptuous and satisfactory lunch dengan cuisine yang sedikit Balinese sepertinya ya hari ini ya. Ada sate-sate yang sticknya itu, kayunya itu lebar. Khas banget di Bali. Boleh yang masih ada di luar, please make yourselves to enter the auditorium. Thank you. As our program will soon commence, we are entering our third and final session for today. But before that, please allow me to convey a few information that may serve of importance for today. Saya berbahasa Indonesia saja untuk yang ini karena memang rasanya lebih tepat. Jadi bagi para partisipan, penyelesaian administrasi peserta yang mungkin memerlukan cap dan yang lain-lain, urusan administrasi, dapat dilakukan di meja registrasi. Jadi bila memerlukan, meja registrasi lah tempatnya. Lalu kedua, bagi yang harus ke bandara segera setelah acara, akan ada shuttle bus. Pukul berapa? 16.30 di lantai bawah. Semoga pas dengan waktu penerbangannya. Lalu bagaimana untuk tahu cara naiknya, busnya yang mana, nanti bisa ditanya ke tim Kemenkes yang juga ada di depan pintu. Jadi 16.30 busnya datang, sebelum itu mungkin lebih baik tanya ke tim Kemenkes, kira-kira busnya akan parkir di depan langsung atau di parkiran mana, mungkin akan lebih jelas. Lalu ketiga, peserta dengan jadwal flight lebih awal dari shuttle bus tadi, Anda dapat mengakses sendiri taksi online. Dan bila memerlukan untuk menulis lokasi, tulis aja UID Bali Campus atau Starbucks, UID Starbucks, pasti akan keluar, alamatnya itu akan ke sini. Itu saja ya. Baik, kita lanjutkan sesi kita pada siang menjelang sore hari ini. Belum sore sih ya, tapi sudah siang. Alright, session 3, welcome back. This is our final session and it will also be an interesting one from a different point of view. For this third session, I'd like to invite Dr. Armaji Kamaludi Sharif. He's from the Ministry of Health of the Republic of Indonesia. He's the Deputy Director for Health Information System Policy, Center for Global Health and Health Technology Policy, Health Policy Agency, Ministry of Health of Republic Indonesia, and he's responsible for leading the team for the Health Information System Policy and supporting national health programs held within the country. Previously, he was the researcher in National Institute of Health Research and Development, Ministry of Health of the Republic of Indonesia. Can you please help me welcome Dr. Armaji Kamaludi Sharif.
Thank you. Good afternoon, distinguished participants, ladies and gentlemen. It is my pleasure to welcome you for the third session today, which will cover innovative AI for robotic surgery, pioneering robotic telesurgery in Indonesia, the experience and the challenges, empower medical imaging using AI, transforming medical imaging with AI, clinical trial, insights from the Indonesian hospital, 3 Indonesian hospitals. So I'm sure this session will be as exciting as the previous sessions. Please welcome to the stage Mr. Fang Wen Zai, the R&D Director of Hangzhou Jianjia Medical Technology. Please, Mr. Fang Wen Zai. Oh, already. And the second speaker, Mr. Dr. Gerard Rinaldi Situmarang, Specialist Urology Consultant, PhD, the Head of Division Medical Service and Development in RSCM Kencana, the Kencana Cipto Mangunkusumo Hospital. Please, Mr. Dr. Gerard Rinaldi Situmarang, please come to the stage. Yeah. Please sit. Okay. Our third speaker is Mr. En Hao Gong, PhD. It's on the Zoom, Mr. En Hao Gong. He is the founder and the CEO of Saddle Medical Incorporation. And our fourth speaker, Dr. Liana Setiawan, SPPK. He is the head of Clinical Research Unit at Darmais National Cancer Center. Please, welcome to the stage, Mr. so we can start the session. For our first speaker, Mr. Fang Wenzai, allow me to read his profile first. Mr. Fang Wenzai is the R&D Director of Hangzhou Jianjia Medical Technology Corporation. Jianjia Medical is a high-tech enterprise dedicated to the research and development, production, and sales of surgical robots and related products. The company is committed to promoting the development of the surgical robot field in China and providing medical institutions and patients with higher quality surgical solutions. The company products include surgery robots for orthopedic and dental surgeries, breaking the long-term monopoly of important joint replacement surgical robots in China. Mr. Fang Wenzai received a master's degree in computer science and technology and completed PhD coursework in biomedical engineering from Tsinghua University. His research interests include computer vision, medical image analysis, and computer-aided intervention. Allow me to welcome Mr. Fang Wenzai. Mr. Fang Wenzai, the floor is yours.
Okay, ladies and gentlemen, good afternoon, and thanks for the invitation in Bali. And my talk today is Innovative AI for Robotic Surgery, and I come from Hangzhou Jianjia Medical Technology Corporation Limited. First, let me introduce my company, and then I'll go through the products and the technologies involved in the company. Jianjia was founded in 2018 with core members from Tsinghua, and now it is headquartered in Hangzhou in South China. The company has GMP workshop with capability of 500 devices annually, and we have raised capital from like Hill House Capital, Tiger, or SoftBank. And we aim to be the leading robot platform in China, and the products include AsRobot, Theta, UseX, and AsPlot, including the orthopedic surgery and dental surgery, and also some compact design and the pre-operative planning software. So let's begin the products part. Here is the image of the main products of our company, including the left AsRobot. It is a three-piece system, and Theta is a quite compact system for dental implantation surgery. And on the right, it is the UseX, the two-set system for orthopedic surgeries. The product portfolio for our company, now we have included surgeries for joint replacement and currently developing systems for spine and trauma and dental implantation. And in the long run, we plan to move forward, expand to sports medicine and also neurosurgery. So for our company, the first question is, why do we need robotic surgery? Let's take the conventional THA, that is total hip arthroplasty. For example, in the conventional surgery, you need to first remove the femur neck and assemble the instrument and follow the step-by-step bone reaming and use the trial for assessment of the implant to see if it fits the bone. And all these complex steps. But with these complex steps, you can see it is very complex and requires the experience of the surgeons. Also, the surgical site is limited and the vision is not so complete. So every surgery step is limited by the human capability which leads to complications and less accuracy and less intelligence and various outcomes of the surgery. So with robots, we have the full visualization prepared before the surgery, and the robot can be regarded as always experience, and the robot helps with each step of the surgery. So we can provide a safety boundary and protect the surgical site, and also the surgery can be more accurate and more intelligent, and the clinical outcome would be more stable. Let's have a closer look of the system. It has 3 pieces. The left is a control system, and the middle is a robot, and the right side is a tracking system. It can be regarded as the brain, the hand, and the eye of the system. For a robotic surgery, not THA, but also TKA, that is total knee arthroplasty, or UKA, or PKA, partial knee arthroplasty. They go through the similar surgical flows, including preoperative planning and the tool calibration and the registration and intraoperative planning. And then the robot executes the plan, and with the execution, it can assess the accuracy in the surgery. Then the prosthesis got implanted. Let's see what the AI or robot do in each step. First, before the surgery, for the preoperative planning, we can see we use AI algorithms for instant 3D reconstruction and detection. That is, we detect bones in the CT and segment the bones and reconstruct it into 3D models. From the 3D models, we can further make multidimensional surgical planning. We can view the plan from the slices and the different views from all orientations. As we can see here, this is a screen capture of the PKA or partial knee arthroplasty, and the green one is the implant. And through this slicer view, we can see how the implant fits with the original native bone. Also, for some surgeries, surgeons or doctors get used to the X-ray for examination of the surgery outcome. So we simulate this effect by the digitally reconstructed radiograph, that is a rendering of the scene after the surgery. So we can see how the implant fits with the bone. And also, we can simulate, if we install the implant, how the patient would move with these new implants. That is, we simulate the motion post-operatively. Note that all these steps are done pre-operatively. That is, we can virtually do the surgery before entering the surgery room. And in the surgery, intraoperatively, we first do the registration. That is, map the preoperative data or preoperative plan to the surgical scene or the actual patient by pointing or collecting points from the actual bone and match them with the preoperative correspondences. We can register the preoperative plan to the surgical scene. That is, as we see in this, this color means they fit together very well. Also, with the registration, the plan can be enforced in the patient. So we developed multi-interactive robot arm motion, including the linear motion, or the fixed point motion, or the planar motion. They are used in different stages and different surgeries. So, for example, these two can be used in the THA to ream the acetabulum, and this can be used in the TKA to cut the femur. In the operation, the system provides a haptic virtual boundary. That is, the surgeon, they operate the system, they operate the robot, but they can't exceed some boundary such that the patient can be safely protected. And this is the main advantages of the robotic solution. Also, Zhenjia has developed several algorithms in this step that includes gravity compensation or zero force dragging, such that the surgeon can interact more smoothly or freely with the robot. In this step, we use adaptive friction and gravity compensation, and also we use real-time AI algorithm to calculate the contact force and the recognition special cases, such as collision with the bone, then which should be avoided. Also, the system provides safety boundary, as I mentioned before. That is a virtual wall to protect the patient. That is called the force position hybrid control. And also, we provided these different patterns of movements for the robot. Also, in the surgery, we can measure the bones, the patient status dynamically and digitalized. That is, we measure, for example, in the TKA, the knee surgery, we measure the joint gap such that the implants can be chosen appropriately. And also, if something happens, it can be adjusted intraoperative. That is the flexible planning intraoperative. Also, when the robot finally acts, it reams or it cuts, in the system, in the computer, it will provide a rendering of the actual scene. As we see here, the bone is reamed, the acetabulum is reamed, and it is rendered simultaneously as the surgery goes. This system is called ArthRobot, short for arthroplasty robot. Here, we have completed over 2,000 robot-assisted THA in China. For the TKA surgery, over 3,000. And both surgeries, they provide better accuracy than the conventional manual surgery. Clinical researches on robot-assisted surgeries have found that in the surgeries, conventionally, surgeons would use the intraoperative fluoroscopy to examine the surgical results, to check if the implant fits and installs well. But with the robot, the intraoperative fluoroscopy time reduces in THA than manual THA. And also, the complication incidence or rate was lower in the robot-assisted THA. For the knee surgery, there's another research. It mentioned that the 3-year survival rate of robotic UKA, that is uni-compartmental knee arthroplasty or partial knee surgery, it is higher than non-robotic surgery. That is, with the robot, we can install the implants better than manually. Also, with the new system, doctors or surgeons have to learn to cooperate with the system. How many surgeries do the doctors need to learn the cooperation? That is, a study has shown that 7 surgeries is enough to learn the robot-assisted THA. And all the surgeries in our research, the implants lies in the safety zone. That is a good part. And the surgery lasts for 65 minutes. That is shorter than a conventional manual surgery. For the THA surgery clinical outcome, there are only 3.2% outliers, that is, surgeries with large deviations than prepared plan. And the angle deviation is less than 2 degrees. To sum up, with us robots in THA, TKA, or PKA, we offer compatibility for these surgeries, and we provide better accuracy, and also with higher safety and better cooperation with the doctors and the robots. So it makes easier and safer for the doctors and the patients. So let's come to another field. This is for dental surgery, dental implantation surgery. The product is called Theta. This system is a very compact system. As we can see here, the vision, the tracking system, the robot, and the order control lies in one-piece design. And this design has won the IF Design Award. And we provide 2 software for planning and navigation during the surgery. So for dental surgery, it should go these several steps. The patient first visit the clinic and take images, and the doctors make the preoperative plan, and then implant was drilled into the patient's bone. So this is called the primary surgery. Then after that, the tooth, the crown, will be made and installed later. So our robot system works here in the first 3 steps. That is, we make the preoperative implant plan, and intraoperative, with the navigation and the robot, we can execute the plan and drill the hole and install the implant. Also, during the surgery, we can assess the drill, the depth, the orientation of the implant automatically. Also, let's see the detail of these several steps. First, with the images, we use AI algorithm to detect anatomy, such as teeth and bones, and all these relevant structures. And we can also automatically combine different images, different data, such as the intraoral scan or the intraoperatively scan. With this data fused, we can make the plan better. And with AI and some data training, we can make the planning semi-autonomously. That is, the system can recommend a plan for the implant, but the doctor can also adjust the plan. In the surgery, the system provides the real-time patient tracking. That is, all the tools, all the surgery robot is tracked, so it can show its position in the rendering. Also, it provides the interactive robot control. As we can see, the doctor, they move the robot inside the mouth. And then this robot can hold to the planned orientation and begin the drilling. Also, the drilling is interactively controlled by the doctor. After the drilling, the implant step is fixed, so we can assess autonomously the depth and orientation of the implant, that is a screw. So with the dental surgery, currently the clinical outcomes show that the accuracy is for the position deviation is less than 1 millimeter, and for the angle deviation is less than 3.5 degrees. It is more accurate than the surgeon's operation. Finally, we'll see another system that it just acquired the national certificate for robot in September. It is called UZEX. It is an all-purpose orthopedic robot. As we can see, it is a two-set system. The robot and the control vision, they are integrated together. And this system, it has multi-indication, and it can work in multi-mode. That is, it works for THA, TKA, and it also extends to spine and trauma surgery. For multi-mode, that is, it can provide the standard operation of the robotic-assisted surgery. Also, the robot can be omitted and it provides a navigation-only surgery. And for THA, we also designed a fast-mode surgery. Spine and trauma is a new extended area, and I will detail it here. For spine and trauma, the surgery we covered is for install screw in the spine, or for the trauma that is such as the femur neck fracture surgery. We fix a screw inside the bone. For all the surgery, we provide the minimal invasive surgery mode or the open surgery mode. And the doctor can choose by their habit or according to the patient's situation. Also, following the other products, we first do the preoperative planning, including the AI-based vertebral detection and the bone segmentation. Also, with the segmentation with the preoperative models in hand, we can customize for the patient and make the preoperative plan intelligently. In the surgery, usually, if for the MIS mode, that is, the bone will not be opened, so it involves 3D to 2D registration. We usually take an intraoperative fluoroscopy to match the plan to the patient. Also, for the open surgery, we can make the point-based registration. All this registration algorithm has been optimized for the spine surgery. And also for the trauma surgery, there's more image processing or stereo vision based algorithm for this registration. Also, we with the registration down, we can conduct the surgery. That is, the robot helps to fix the screw inside the bone. Also, it is an interactive process. Okay, after all the introduction of the products, let's view the panorama of the surgical robot technologies in our company. As we can see here, we make a layered modular design and highly scalable software and hardware interfaces, including this from infrastructure to algorithm to module to application, all these layers. With this infrastructure, so we can adapt our system to new robot or new tracking system or extend to new medical field to make more robot system for the other surgeries. Currently, we mainly focus on the development of surgical robots. And we are currently still developing, such as the sensors and the medical cloud. The sensors can collect data intraoperatively, such that with this data may be not available for all the surgeons before. So with robots, with this sensor data, we believe we can make the surgeries more standardized, also more digitalized. And also the medical cloud, that is like Dr. Liao mentioned, the cloud-based solution for the image analysis or preoperative planning. This can be combined with the planning software we also have already designed. So with the cloud, we name it the GMAD cloud. We can collaborate with the implant manufacturers such that with our open platform design, and we can make more implants integrated in our system and also make the surgeons have more choices. Also, we collaborated with the clinics and hospitals for this data and improve the algorithm for image, for robots. Finally, we can improve the robot system. We believe with the AI algorithms, with the robot, and also the sensors, the web-based system, we can make much more work in the medical cloud, medical field, and make the surgeries better, easier, safer for all people. Okay, thanks for the attention.
Thank you, Mr. Fang Wenzai, for the insightful presentation. You can sit back to the chair. Thank you. Our next speaker is Dr. Gerard Rinaldi Situmorang, SPUK, a consultant, a graduate of the Faculty of Medicine, University of Indonesia, completed his PhD at Newcastle University. He has a keen interest in the field of kidney transplantation, pediatric urology, leadership, and management. He has participated in numerous training related to kidney transplantation and urology and has published several papers on these topics in various international journals. Dr. Rinaldi will share his thought on pioneering robotic telesurgery in Indonesia, the experience and challenge. Dr. Rinaldi, the floor is yours.
Hi. Good afternoon to us all. Thank you very much, Mr. Moderator, for the kind introduction. It's always a pleasure to be here talking in front of you. I have to confess that I'll probably the least knowledgeable person in terms of information technologies and robotics and AIs, but I'll try my best to emphasize or to look at the applications of AIs and robotic surgery from another aspect or another perspective, which is the user perspective, or how the technologies can actually be implemented. I believe we have several slides before this. And before, oh, okay, that's kind of the title of the surgery. So the title of the presentation. Again, my name is Aldi. I work in Cipta Mangunkusumo Hospital, one of the vertical hospital under the Ministry of Health. And just a few months ago, we had the opportunity to perform a telerobotic surgery, the first in Indonesia in human, and the first, to our knowledge, to the best of our knowledge, in Southeast Asia. And this is our experience. So I'm going to provide you with a different perspective of how the technology can be implemented in a day-to-day practice. Slide, please. So this is our dream. What if we have a doctor, say in Jakarta, and we can perform a sophisticated surgery for a patient in Papua, for example, for a difficult disease, say a radical prostatectomy, which is performed in patients usually with prostate cancer. And we know for sure that robotic surgery has the advantage of magnifying the operating field, ensuring that you don't touch any unnecessary nerve that does not need to be touched, and you're actually working in a very confined area, sort of behind the pelvic bones. And all these can be beneficial if you have laparoscopic surgery or robotic surgery. Laparoscopy can be difficult, but robotic certainly is more manageable. So this is our dream. But how can we make this dream happen? That's another question. And that's the story that I'm going to tell you. Slide. So first of all, doctors, ladies and gentlemen, I think we need to understand why is telesurgery even necessary. I think there's a number of papers that have actually been published in this area. And the summary of these papers says that telesurgery can actually provide high-quality surgical services in hard-reach areas, so in remote areas. And of course, there's no need to travel and can reduce both costs and the risks, which is associated with transportation, if you would like to say that. And it provides a high-quality three-dimensional imaging to multiple doctors simultaneously. So if we have several consoles in different areas, that is probably an important educational tools. It enables real-time collaboration between multiple surgeons in different locations. That's the dream. Maybe we have a thoracic surgeon, an expert in thoracic surgery in one area, an expert in urology in one area, and all of them can actually work on the same patient. And the fifth, but not the least, is eliminating physiologic tremors. Some people are just born with tremors. We have to appreciate that surgery is a field that is closely related to the skills of a person. And sometimes people have that tendency to have tremors. The applications of robot actually reduces that tremors. Slide. This is the brief history of, okay, thank you. Thank you. See, I'm the least knowledgeable in terms of IT. So, history of telesurgery actually dates quite a while ago. The first one is in 2001, so almost more than 20 years ago, 24 years ago, in Strasbourg, France, performed by Professor Jacques Marescot. But that is not a really remote, sort of not very far. We had our first telerobotic surgery to an animal in 2023. And the most remote telerobotic surgery ever documented in the world is performed in 12th of June 2024 by a professor in Beijing. And the patient was in Rome. And from my experience, this is a massive undertaking. And I'll tell you what in a moment. This is our first experience Indonesia's first robotic telesurgery in human. At that time, we had our patients in Kencana, in RSCM, in Cipta Mangunkusumo, and our operators were in Ngurah Hospital. So we had 2 operators working from Ngurah Hospital, whilst the patients were actually in Kencana Hospital. We had Professor Agus Rizal, our oncologist, urologist, in Ngurah Hospital, and from Cipto Mangunkusumo Hospital, and Prof. Poncho Biro, our andrologist, also from Kencana Hospital, but we actually flew them to Ngurah for demonstration purposes. At that time, this is the event why we actually had that idea, because at that time we host a Urological Associations of Asia meeting, which has not been held in Indonesia for quite some time. So we feel that we need to display something which is, groundbreaking at that time. It was attended by more than 3,000 participants from almost 55 nations, which is on last September, so last month. Again, this is the team in Ngurah Hospital. As you can see here, although we had our surgeon flown from Jakarta, we have to make sure that Jakarta team also have the same capability of surgeons. Because if anything ever happened, God forbid, that the connection is lost or something like that, then we need people with the same expertise to actually intervene the surgery and perform the surgery using a more conventional tools, such as laparoscopic surgery or even open surgery. This is the team in Jakarta. At that time, we had the opportunity that our Minister of Health came to the facility and looked at the operation directly. Again, the same qualifications of surgeon has to be on site just to stand by if anything happened. This is the OR that the operation was taken place. This room here was actually isolated from the main OR, and that's the picture at the top is the main OR, which also had the capability of fluoroscopy, so hybrid OR, in the private wing in RSCM. We didn't stop during only in one case. We performed another more complicated case, which is a radical prostatectomy. The surgery is understandably longer than the first one because the case is more complicated. And to ensure that there's a limited distraction because of the bandwidth and so on, we chose to perform the operation here in Bali. So both the operators and the patient were actually in Bali, but the operators were in a different site, just to demonstrate that telerobotic surgery is feasible to be performed. It was performed in September the 5th, so in conjunction with the opening of our meeting. And ladies and gentlemen, of course, this is not an easy task, and I'll tell you why. The first thing is we have to acquire the robot, and the robot is expensive, especially when it comes to Indonesia. The transport, the tax, and so on, it's considered as an expensive goods. So acquiring the robot is expensive. Internet connection is also a problem, because to ensure a proper internet connection, very slow latency time, you need a point-to-point transmission. So you cannot just use an ordinary internet connection. You have to have a good teamwork with communications, and this teamwork, the reasons why I display a lot of names since the beginning of my presentation, because this will not be possible without the presence of those experts. Even the experts behind the scenes, the one that stand by needs to be there, they also play a significant role. And it needs real-time troubleshooting from the company that supplies us the robot. They need to be there. The telecommunications experts needs to be there. And it takes quite a lot of troubleshooting between these parties. Again, we cannot do this without the help of our Ministry of Health, and Telkomsel at that time, because otherwise the connection will not be sustainable. And before that, or prior to the surgery, we have to have our expert trained. The reason why there are only 2 or 3 surgeons that perform this surgery is because taking a license to perform surgery using robotic technology is like a pilot. You need to be trained using that specific tools. So if you're driving a Boeing 747, you need to be trained using Boeing 747. If you change the plane, then you need to be trained using the other or another plane. The same thing with robot, because every robot will slightly have different, slightly different ways of controlling or troubleshooting, and you need to master that. This is the sort of the topography of all the tools and equipments that is involved in performing the surgery. Again, we have our team in Jakarta dealing with the patients, ensuring that the patient chart is working well. We have one dedicated connection all the way to Ngurah, but the Ngurah experts need to ensure that the connection is working well. And then during the operation, as I've told you before, we need experts also to back up the operations. It's transmitted using cloud and internet. So again, the experts in technologies, in telecommunications is crucial. In terms of acquisition of robotic technology, as you can see in these statistics, then Indonesia is probably one of the slowest in acquiring the technologies when compared to our Southeast Asian friends. Even Vietnam have 6 robots, and this probably occurred 2 or 3 years ago, whilst we currently have only 2 robots, one in private sectors and one in RSJM. Hopefully the robots stay in our possession for a long time, because otherwise it's probably going to be brought back to where it comes from. And of course, when you compare that to the number of population and the number of cases, I think we need to work more. I think we need to change the perspective on how robotic technology can actually help us in delivering a better healthcare for the people. As I've told you before, this is not our everyday connection. The upload and download capabilities needs to be above 100 megabytes per second. We need to set up a dedicated line for this. The latency time, that means, when you move the controller in Ngurah, it needs to be transmitted to the arm of the robot in Kencana in less than 25 milliseconds. It's good that we can achieve 10 to 11, 12 milliseconds during the surgery, so everything went fine. The jitter is actually the even the finer movements. It has to be below 0.5 milliseconds, and the packet loss is below 0.01%. We managed to achieve this with the help of dedicated telecommunication experts team. So we really need to bring the guy from Telkomsel to sit down and sort out the problem, because we tried this several times and the numbers just didn't go down as well as we expected. But once everybody turns up and everybody has the same vision, it's actually doable. It's actually feasible. And of course, there's no room for error, as we're dealing with human lives in a real-time fashion. Again, a dedicated line needs to be installed in our OR, so it takes quite an effort to put this line in and connect it to the already established line just outside Kencana or RSJM. This is our surgeon that has undergone training in the robotic training center, again dedicated for that particular robot. There are a lot of training and certifications for robotic surgery. This is one that I attended. Again, in this center, I only learned robotic kidney transplantation. And there are various workshops as well, radical prostatectomy. And as you can see, the robot is different. So different robot will have different training. And the cost of training is not cheap. It's one of the most expensive workshops that I've ever paid. So but it's a long-term investment, and we know that we should, move up or move towards that direction if we want to compare ourselves or compete with world best centers. And as you can see here, in that training center, the consoles are actually two. So there are not only one console. This allows the mentor to intervene the control should anything happen. In the training, I perform surgery in porcine models. So if there's any bleeding and the mentor needs to bypass the surgery, then he's able to do that using the second console. If you need to do if you want to perform a proper mentoring on robotic surgery, then you need two consoles. The price of one console is, again, not cheap. And as the previous speakers have repetitively mentioned, I think the work between human and robot to deliver the best of service requires teamwork. And the teamwork is between doctors, between human, as well as the robot and the technology. We need effective communication. If you can you click on the pictures? There's actually a video that people can see. Is that clickable? It should be. Well, anyway, again, it shows my... So, effective communication and strong team collaboration are key components in telerobotic surgery to avoid clinical incidents. And given the constraints of space and time, every surgical action requires intensive coordination among team members. So the robot will only have 4 arms, and usually the one arm is for camera, so you only have 3 arms to work with. It's not rare that you need another arm to perform suction, to put in clips. So the surgeon in or beside the patient needs to know what he's doing, even though you are located far away. So what it is for us going forward then? I think now that we made history, the next step we should use robot to disseminate expertise. We are lacking of doctors with subspecialty competence in Indonesia. And to educate or to train one subspecialty will require at least 2-3 years. Having robotic technology can help that. It doesn't negate our needs of competence. We still need the competency, but it can help accelerate things. And of course, we've always dreamed of delivering world-class service to remote areas. I mean, patients in Papua have the same rights to be performed radical prostatectomy as patients in Jakarta. The only problem is we can't deliver it to them. Whether or not robotic surgery in the future can provide us a path to do this is another matter. But I sincerely hope that we can do that. Proctorship, the more people that has been trained in robots, the more we have robots in robotic surgery in other locations, of course we can ensure a proper training. And introducing robotic surgery into the curriculum, I think that's a nice way of actually introducing the technology to the people in training, to the younger urologists. And how about incorporating artificial intelligence in robotic surgery? And as the first speaker has shown in his slide, the investment to use artificial intelligence in robotic surgery is actually one of the highest investment that has been documented up to now. So this is the take-home messages. Telesurgery presents significant potential in the surgical field and transforming what was once we consider a science fiction. However, achieving this is not an easy task. As a preparation of a single type of operations require months and substantial resources. That's our experience. Nevertheless, it is, every major advancement starts with the first step. So why not start with the first step? And we hope that successful implementation of the first telesurgery will serve as the catalyst of the accelerations of robotic surgery in Indonesia. And of course, ultimately enhancing the quality of healthcare to meet international standards. I would like to close this presentations by quoting these 3 sentences. One, robotic, I think, will not replace human existence. At the bottom, robotics is about us. It is about discipline of emulating our lives, of wondering how we work. The robots can only imitate what we do. It can only better what we do. So we really need to take command and use this technology. So we do not need to be scared. That's the message. And every life deserves world-class care, as nicely put by Cleveland Clinic, and certainly robotic surgery may provide a way of delivering that world-class care to even remote areas. And as our first president mentioned, gantungkan cita-citamu setinggi langit, jika engkau akan jatuh di antara bintang-bintang. It's not a sin to dream, so we dream high. When we fall between the stars in the sky. I think that's the message of our presentation. Thank you very much, and I would like to acknowledge these people for contributing to the event. Thank you.
Thank you, Dr. Renaldi, for your insightful presentation. Okay, next, joining us virtually, our third speaker for this session is Mr. En Hao Gong. Mr. En Hao Gong, PhD, is the founder and CEO of Saddle Medical Incorporation. Saddle Medical is the world leader in applying deep learning to acquire medical images to enable faster, safer, and smarter medical imaging. Saddle Medical is committed to transforming the healthcare ecosystem by building and delivering responsible AI solutions that help serve more patients with better radiology workflow and patients' experience. Saddle Medical has obtained 8 FDA clearance and regulatory clearance globally and deployed in more than 600 sites globally in top hospitals and imaging centers. Mr. En Hao Gong holds a bachelor degree of biomedical engineering from Tsinghua and PhD in electrical engineering from Stanford University, where he researched deep learning in medical imaging. His work on MRI reconstruction based on deep learning and generative AI models was featured and recognized by academia and industry, including Forbes 30 Under 30, Fortune 40 Under 40, NVIDIA AI Award, etc. Mr. En Hao Gong will share his thought on empower medical imaging using AI. Mr. En Hao Gong, the screen is yours.
Can I use the presentation on my side because I adjusted it a little bit? Is it okay?
Yeah, it's clear.
Okay. Hi everyone, it's a great honor to have this opportunity to join remotely. I'm right now in Silicon Valley and to share how we empower medical imaging using AI and with a focus on how to continue the clinical exploration and continue AI innovation with the state-of-the-art AI and generative AI model. We do find a focus we are working on is using AI to improve imaging acceleration and enhancement at Saddle Medical. A little bit background for Saddle. So I co-founded Saddle Medical around end of 2017, early 2018, with my co-founders, Dr. Greg Zahacek, who is a radiologist and professor and neuroradiologist at Stanford. And basically, we have a lot of technology developed at Stanford, much from my PhD experience at Stanford. And we have a license from Stanford to commercialize this technology because the thought is really AI have a lot of tremendous value in healthcare, especially medical imaging. And conventionally, how this technology get adopted is really mostly pushed by the big vendors, and that's really a 5 to 10 year, even longer product cycle, and using mostly focused on device hardware. It's 5 to 10 years longer product cycle compared with AI that's changing every day. So we believe an AI-centric approach is the best way to really bring AI and sterile technology to clinical applications. So we license our technology and we found a company. Right now we have a team of around 50 people in US, around 30 people in APAC area as well. And not only like on the technical side, but really focus on developing products and commercializing it. The team has a track record to really learn and explore and prove ourselves to scale the product line and to deploy in the clinical settings and commercialize it. And what we focus on is really we find the big pain point and opportunity as well is on the upstream of imaging workflow. And so there's a lot of company using a lot of different technology to do the downstream. Here I show on the right-hand side, it's a downstream. most radiology AI companies using AI to form the radiology test as image classification, detection, segmentation algorithm. And for that, previously, I think there's a lot of talking of using AI to replace radiologists, but that's more on downstream diagnosis tasks. It is a lot different deployment and progress going on, but it's often overlooked is the upstream pain point opportunities, because the majority imaging cost is actually not in downstream, it's in the service line. It's a majority of cost, and the bottleneck for efficiency is also being a way bounded by the efficiency of data acquisition, of when the patient get into a scanner and get out. So when a patient is waiting to schedule exam or waiting in the hospital to get exam, they are really waiting for the service line to open a space and time to get to use the device to acquire the high quality data. And this also means improving the data acquisition, visualization, basically in the data generation process, can really provide immediate financial return to provider, because it means hospital imaging center can serve more patient better. Per patient level is better quality, better outcome. But from the holistic perspective, they can really improve the service capacity to serve more patients, which means more efficiency, top line, etc. So that's what we've learned from years' experience in clinical imaging. We find it is an untapped market and untapped need, unserved need to using AI to improve data workflow, improve how the data is generated, improve the data quality. So that's what my research has been focused on, and what the company Southern Medical has been focused on, using AI not to replace radiologists, but really empower radiologists with better data, at the same time, it's a really clear clinical and financial ROI to hospital imaging centers. The technology is built based on, as mentioned, the research we have done starting from Stanford side. We also found one of the first group and researcher globally really focused on develop AI and journey model technology to improve the data acquisition, starting with MR reconstruction task. So all the medical imaging is in a way not really scanned pixel by pixel. So the way to improve the imaging efficiency, to reduce the time the patient need to stay inside scanner, is really using advanced technology. Here we start with deep learning, general model, UNet to start, and later we got into transforming, etc. All the state-of-the-art model architecture can, here is not replace radiologists, but really replace how the image reconstruction, the inverse problem solver for medical imaging. Because all medical imaging is acquired in certain domain using image physics model, and then convert into image or volume domain so clinician can review it. So since around 2015, we start applying different type of deep learning technology and really show deep learning and really it can provide better quality in terms of acquiring data faster, using faster exam, but generate much higher quality in terms of results. And we deploy this technology to 100 sites globally. Right now, we have more than 600 sites. As mentioned, across around, we have 8 FDA clearance across 4 major directions, and right now serving 2.5 million patients a year. We also get more launch in APAC area. We already have some hospitals in Singapore deployed. We are looking forward to getting to help more patient and providing in Indonesia for sure as well. And so majority of the customer in US, Europe, APAC. It's the 3 major regions we have been pushing a lot for our technology. In short, AI technology enable around 4 times faster and better quality in terms of advanced imaging, including really focus on MR and PET because it's the most inefficient and high, like a hand exam, and that's been used as golden standard for a lot of diagnosis. Our first clearance start with SATA PET is using AI to improve 4 times faster or lower dose for PET imaging. Similarly, we expand to MR for around 2 to 4 times faster, better quality. And this year, we actually got 2 new FDA clearance to go beyond the starting point. Usually, we start with super denoising and super resolution, but really the journey model enable us to do more things, starting with like data synthesis, so we can synthesize different sequences using existing data, and we publish paper to show certain sequences we can synthesize in a way fast enough and actually additional speed up compared with existing exam, but also even better quality than conventional methods. And the other direction is on pharmaceutical usage in radiology exam. Around a third of imaging exam, you need to inject certain pharmaceutical contrast dye to visualize the tumor. The region need to inject such high dose sometimes is really to make it easy for radiologists to tell the difference. But from technology, from AI perspective, we can use less dose or we can visualize the differences way better. So we have developed several AI technology collaborating with pharmaceutical company to help improving the visualization of lesion better, both qualitatively and quantitatively. And all this been published a little paper to validate it and get different regional clearance and to show it's been needed globally. And I want to talk more on the impact of all this technology because I think this really, we kind of pass through the phase that there are a lot of hype and there's a lot of concerns on clinical adoption of AI. I think right now, for all this conference, all this discussion, more and more clinician decision-making really focus on what's the real value of AI. And mostly it's really not about replacing radiologists, it's about what's clinical value and the financial operation value to the hospital image center. We have shown using AI to improve the data generation can significantly increase the workflow efficiency, which means you can boost the service capacity per scanner, per size, per hospital, can serve more patients per day. So that's really can transform to a lot of operation value. And help serve more patients better means a lot on access as well. I think previous speakers has been talking about it's really important to improve the access for different patients in different geolocations. And so I also learned lately, like in Indonesia, for example, the MRI scanner is not everywhere. So there are a lot of limitations to get into the exam. And because the scanning time is really the major bottleneck for to limit the number of patients per scanner can serve, it's really important to using AI to improve the service capacity so we can, for the hospital image center, have the high-end scanners, we can serve more patients per day. And from patient perspective, it's better access, as mentioned, and reduce the waiting time. There are several papers shows we have also done a survey. A lot of patients, especially for oncology patients, they really value a lot for an exam that can just get it done in 5 minutes versus 15 minutes. So it's really important to improve the patient experience, which also leads to better outcome. And from the data perspective, improving the data quality we have shown can lead to better diagnosis accuracy, can improve suboptimal exams, which are very common due to motions, due to different kind of artifacts. And last but not least, it's also about access because you need to standardize all the data, no matter where it's from, which hospital, which location part, which type of scanners, technology, and technologists that run the exam. So it's really about standardization using AI. And from the
your voice is not audible. You're not audible, sir. Mr. Enao.
Hello?
Yes, yes. I can hear you now. I can hear you now.
So am I breaking?
Yeah, breaking for quite some time.
Oh, is it better now?
Yes. We can hear you now.
Okay. Let me repeat this slide. Is that okay?
It's okay. If you would like to repeat the slide, it's okay.
Okay. I don't know how much I've been breaking.
Maybe halfway. Maybe halfway.
Okay.
We lost you halfway.
Of this slide?
Yes.
Okay. So yeah, I guess I talk about increased workflow efficiency, patient experience, and data quality. And for data quality part, it's really also about standardization across different sites, different scanners, different patient population. And last but not least is really the operation value. So it's very clear improving the imaging speed can improve the top line and the service outcome, which can lead to very clear financial return adopting AI here. But at the same time, you can reduce the cost and total cost of ownership. That's usually of concerns for hospitals purchasing and maintain advanced imaging devices. And we can optimize the spending and come to purchase. It's really the idea is using AI to upgrade entire fluid scanners, no matter with all different vendors, because our technology is compatible across vendors. compatible across different age of scanners. And last but not least, there has been shown environmental value because using this can reduce the carbon footprint in general idea. But the general idea is really using AI to improve the upstream opportunity, improve data generation, and not only lead to clinical value, but leads to a lot of financial value to customers, to hospital centers. So I think that has been a driving factor for them to adopting AI nowadays. It's not only about what kind of accuracy, what kind of ROC it is, but really it's about like the clinical value has been validated by papers and the operating value that's been seen by the decision makers. So we also design and we're collaborating with industry partner like NVIDIA, Intel to improve the deployment for this technology. So in a way, it's compatible with other scanners, but we do not need to integrate it inside each scanners. It's really about data integration. We get the first-hand data from a scanner, enhance it, improve it, and send to the downstream to the PACS. So all this can be designed in a seamless way, so it's kind of plug and play. There's no delay. We have been deploying all over the world, and it's for different workflow, for different scanner, different setup. On the IT side, it works because it's really about data communication. And so that leads to improve in terms of the workflow efficiencies, and there's not too much training, and we can land expand within enterprise, within hospital enterprise to scale it. There are several case studies I want to showcase. For one is in US, is really a hospital setup. We have shown in the clinical setting and also work with Mount Sinai's top hospital to publish paper at Radiology AI to show we can using our AI to improve the efficiency, really get down to scan time reduction and around 2 times slot time, scan time improvement, which means potentially the hospital can double their throughput, serve more patients a day and with better quality. And a lot of imaging is done outpatient in US. For image center and image center network is the same. We can show across different scanners, different devices, different patient populations, they're around 30% up to 50% plus value, which leads to clinical value and financial value. We have done deployment around, I think, more than 100 hospitals in China as well. It's really in China, we're scanning back to back. There's not a slot. Patients just get in and get out very quickly. And we have shown in that setup, we can also lead to 30% up to 45% speed up or of the slot time, like percentage more patient, and basically make a little aging scanner to be as efficient as brand new. So, and I think the general idea is that is really helpful from the hospital perspective. And for us, we really want to push the boundary of AI-powered imaging. We'll start with denoising and super resolution algorithm, and we'll collaborate with a lot of universities to really improve next generation technology, including the AI-powered synthesization, standardization, workflow efficiency, quantification biomarkers, and eventually, I think the idea is to really end-to-end workflow solution to generate better quality and better data workflow. And given the time, I will just quickly go through some of the examples. General idea is this. With AI and similar technology like ours as well, but the general idea is using AI to improve the data acquisition can lead to around, say this one is 2 times faster exam, but actually better quality than before adopting. So there's really a no-brainer to adopt it because it's improved both quality and reduce the cost. So I think that's the general idea of the on the upstream technology. We'll just quickly go through is applicable for different body part and different modality. We have been working on with some nuclear pharmaceutical company on the PET tracer as well. We can enable around 4 times lower dose, but even better than the conventional imaging. This is for the kidney and for the different different tracers. The idea is to enable lower dose, better workflow, but even better quality than standard care. And there's also working on improved visualization, the detection of lesions, and to generate better contrast. So I think that this is the general idea of continue push the boundary of AI-powered imaging. And there are several components. Start with the data set on the left side. That's because all the AI company is really working on to continue improve the data generation and accumulate the data advantage. For us, we have been working with top hospital imaging centers to enable that. And so it is not only the quality, the quantity of data, but really the quality, and really for us, the AI enhancement tasks, both input and output is not some data you can just purchase from a hospital. You really need to change the workflow, make it faster, lower dose protocol, and that for input, and change the protocol to be, say, 2 times longer, high golden standard protocol for the ground truth output. So in this way, we have been working with our clinical partner to acquire different data sets to continue to improve the model. And from technology perspective, there's a lot of development even every day on AI and generative AI model. And so it's kind of like translation also into medical imaging applications from UNet, CNN to right now more like Transformer, Mamba, like this type of technology, like different architecture. But there is really we can leverage state-of-the-art technology to improve the image enhancement. And last but not least is really not only develop technology but really adopting it, so to enable more clinical applications. For example, we're working with pharmaceutical company for better biomarker, because it's not only generate better looking image, but really about its quantifiable, quantitative like biomarker, the value for clinical application tasks. And so, for example, we have this image we are working with a downstream brain imaging quantification company, and to enable around 3 times faster brain quantification for AD disease analysis. So I think that's will be transformative for all this biomarker analysis. Will be really transformative, combining with AI that's make the imaging higher quality, better precision, and faster. So it can enable the adoption. And last but not least, a few kind of outlook of how this technology enable. Start with pharmaceutical opportunities. As mentioned, we have the technology making imaging faster and potentially lower dose for radiation dose, but also for contrast pharmaceutical dose. We're working with both MR and CT contrast company and the PET radio tracer radio isotope company to improve technology to enable around up to 10 times lower dose, but better visualization. So I think that's the next generation of contrast or pharmaceutical products in radiology will for sure be the one that's not only just deliver as a drug, but really deliver as like a drug plus AI. And we have shown several clinical applications to really push the visualization, push the data quality. So this can help to visualize the details that's hard to see, that's enable better screening and opportunistic diagnosis. That's been very popular topic nowadays. And also, by improving the device, we can overcome certain limitation on the immunophysics side. So we can use the AI to improve the quality of like ultra low field scanners for MR to make it portable for different kind of intervention applications. We have published papers and with company as well as hospitals to show the value of AI, not only in routine clinical imaging, but really in portable MR applications.
Mr. Enhao, the time is up.
Yeah, I think the final idea is by generating better data with multimodality integrating the workflow, we can enable better end-to-end solutions. So it's empower instead of replacing radiologists. Thank you.
Thank you, Mr. Enhao, for your insightful. Yeah, round of applause for Mr. Enhao Gao. Thank you, Mr. Enhao. Next, our fourth speaker for this session is Dr. Liana Setiawan, SPPK. Dr. Liana Setiawan, SPPK is a graduate from Faculty of Medicine, University of Indonesia, completed her PhD program at the Faculty of Medicine, University of Indonesia. She also completed a subspecialty in oncology and clinical pathology at Gadjah Mada University, Yogyakarta. Her current position is head of the clinical research unit at Darmais National Cancer Center. Her publication cover a wide range of diseases, including cancer, thalassemia, infections, and autoimmune diseases. Dr. Liana, the floor is yours.
Thank you, Mr. Moderator, for the kind introduction. Good afternoon, ladies and gentlemen, and for our Mandarin-speaking guests, I guess ni hao. If can I have a permission to speak in Bahasa? I think it may be better to convey the message to our guests, and but my slides will all be in English.
Please.
Okay, so the topik yang diberikan kepada saya hari ini adalah Transforming Medical Imaging with AI, Clinical Trials Insight from 3 Indonesia Hospital. Mungkin sebagian dari rekan-rekan di sini berpikir ini ada urusan apa ya, seorang spesialis patologi klinik ngomong tentang imaging AI. Jadi sebetulnya kalau saya sendiri pasti tidak bisa membahas tentang ilmu radiologinya, tapi lebih ke arah clinical trial-nya. Kenapa kita harus melakukan clinical trial untuk teknologi yang baru ini? Jadi ini sebagai latar belakang kita tahu bahwa beban kerja radiologis saat ini makin lama makin meningkat. Dan kita lihat satu orang ahli radiologi itu dia ilmunya tuh benar-benar banyak banget, dia bisa mendiagnosis banyak penyakit dari imaging, dan dengan makin majunya teknologi imaging saat ini makin jelas kelihatan ya kalau misalnya ada kelainan atau apa. Tapi dengan beratnya beban kerja, teorinya nih beban kerja ini bisa menyebabkan lama-lama nih kalau orang kelelahan kan diagnostik error bisa terjadi. Selain itu juga sebetulnya antara pembaca itu ada perbedaan. Dan ini sesuatu yang mungkin bisa diperbaiki atau bisa dibantu dengan adanya AI. Jadi saat ini kita berpikir potensi AI itu bisa digunakan di radiologi untuk membantu dalam interpretasi kasus. Kemudian juga seperti tadi yang disampaikan oleh Dr. Enhao, itu juga bisa dalam hal non-interpretatif ya, jadi dalam hal workflow, enhancing kualitas dari image-nya juga. Dalam praktek klinis sendiri sebetulnya gimana? Ini ada beberapa studi di negara-negara barat yang sudah cukup lama terpapar dengan AI radiologi ini. Jadi ini studi tahun 2020, ada 1.427 respon. Dan yang menggunakan AI di dalam praktek kliniknya itu ada 33,5%. Tapi yang menggunakan AI ini 80% bilang kayaknya kurang benefit. Dan ada yang bilang teknologinya terlalu mahal. Ada juga ini laporan dari US ya, katanya hasilnya banyak yang tidak konsisten. Sedangkan ini dari Eropa, jadi ada 690 responden, 40% itu punya pengalaman dengan AI. Jadi tadi kalau di US itu 33,5, di Eropa itu 40%. Dan dari pengalaman mereka sendiri, yang tadi punya pengalaman dengan AI itu 40% ya, 180 responden, menurut mereka itu 75,7% algoritmnya itu reliable. Jadi sebetulnya cukup bagus ya. Tapi ada juga yang nggak berkomentar. Oke. Nah, kalau ditanya mau beli nggak? Yang mau beli cuma 13,3%. 52,6% bilang tidak, dan 34,1% nggak menjawab. Untuk masalah workload yang tadi kita pikirkan merupakan salah satu pendorong untuk penggunaan AI dalam radiologi. 4% bilang, oh ya workload kita berkurang dengan AI. 48% malah bilang, kok workloadnya nambah. 46% bilang, oh sama aja. Ini saya ngitung nggak sampai 100 ya, ternyata 2% nggak ngasih jawaban. Terus ditanya alasannya kenapa, nggak mau beli. Yang pertama merasa, oh ya no additional value. Yang kedua, kayaknya nggak sebagus iklannya deh. yang ketiga, pekerjaan tambah rumit. Dan cuma 6% yang bilang nggak ngasih alasan. Sebetulnya ini agak mirip dengan digital imaging yang ada di lab. Jadi kadang-kadang kita kalau misalnya sampelnya banyak sekali, kita justru merasa lebih enak ngelihat di mikroskop langsung. Karena melihat di komputer itu kadang-kadang matanya pegel. Itu juga mungkin salah satu kendala untuk penerapan AI. Ini adalah beberapa batasannya. Jadi algoritmenya, jadi AI ini salah satu yang sangat berguna itu mungkin algoritma untuk bantu interpretasi. Itu belum tentu bisa sama performance-nya di klinik dibandingkan dengan apa yang mereka sudah lakukan validasi internal sendiri pada waktu mereka manufaktur. Selain itu juga kalau misalnya mungkin ini analoginya kalau di lab ada sertifikasi dari US FDA. Nah sertifikasi ini mereka ada syaratnya sendiri. Kalau kita merubah sesuatu itu tuh langsung sertifikasi itu berubah. Jadi kita harus validasi ulang. Nah dan kadang-kadang kan dalam praktek klinis kita sering ketemu guideline-nya berubah. Kemudian di negara-negara yang berbeda tuh kadang-kadang prevalensi penyakit atau insiden penyakitnya beda atau bahkan alatnya berbeda. Kalau untuk manusia mungkin adaptasinya lebih mudah ya, tapi kalau untuk regulasi itu enggak semudah itu. Jadi untuk kita dapatkan sertifikasi beda. Begitu kita merubah sesuatu dari sistem ini, sertifikasi yang tadinya ada itu sebetulnya sudah enggak berlaku karena kita sudah merubahnya. Kemudian AI ini harus selalu di training. Jadi kalau misalnya ada perubahan, dia harus ada adaptive training juga. Jadi direkomendasikan bahwa produk AI itu harus divalidasi secara lokal dengan data dari lingkungan di mana mereka akan diaplikasikan. Dan itulah sebabnya kita perlu melakukan uji klinik. Ini adalah kondisi saat ini, jadi ini saya ngambilnya dari publikasi tahun 2023. Untuk yang algoritma AI yang sudah di-approve oleh FDA itu ada totalnya sekitar 201, itu sampai tahun 2022. Dan kebanyakan itu untuk neurologi, jadi mungkin CT brain ya. Kemudian ronsen toraks, kemudian radiologi untuk payudara dan muskuloskeletal. Dari yang sudah di produk yang tadi kan FDA, ini ada yang CE-mark. CE-mark itu ada 100 produk, tapi hanya 36 yang sudah diteliti, jadi ada peer review evidence-nya. Dan peer review evidence ini diantaranya yang 36 itu, 27%-nya itu untuk technical dan clinical feasibility. Kalau 65% itu untuk performance-nya. Sedangkan kalau yang 27% sisanya itu dia melihat impact klinis dari algoritma ini. Oke. Dan kalau yang dari yang FDA approve itu yang terlapor sudah ada validation study-nya ternyata nggak banyak. Cuma 16%. Itu. Dan sebagian besar itu memang belum ada validation dataset dari pasien-pasien yang secara geografi atau rasial itu bervariasi. Jadi untuk clinical trial di AI ini sampai tahun 2023 itu tuh hanya tercatat ada 128 clinical trial dan sebagian besar itu masih dalam tahap rekrutmen. Jadi memang kalau kita lihat masih banyak sekali yang perlu dilakukan sebelum AI ini bisa ditranslasi dalam praktek di klinis. Oke, yang kami lakukan saat ini adalah melakukan uji klinik untuk memvalidasi kegunaan dari suatu AI yang diproduksi oleh Harrison, itu namanya adalah Analyze AI. Nah, ini adalah fiturnya. Jadi kita melakukan untuk 2 use case, yaitu yang pertama itu untuk CT brain dan yang kedua itu untuk CXR, jadi ronsen thorax. Jadi ini brosurnya, kita bisa lihat bahwa fiturnya adalah yang pertama dia bisa mengurangi kita bilangnya near misses itu kejadian nyaris cedera. Kemudian ada mata kedua nih, karena dia didesain itu untuk sebagai assistance untuk radiologi. Kemudian juga dia membantu dalam worklist triase. Nah, dalam pengembangannya dia sudah menggunakan data yang cukup banyak, dan ini trainernya itu banyak loh, 140 radiologis. Nah, jadi tadi kita bisa lihat datasetnya tuh 229.000. Nah, di antara hasil temuan yang dilaporkan, mereka bisa mengklasifikasikan item temuannya itu 130 untuk CT brain. Ini adalah untuk ronsen thorax, jadi kurang lebih sama, ini brosurnya. Ya, jadi kembali dia second pair of eye. Jadi radiologinya tetap pembaca utama dan AI ini adalah support pendukungnya. Jadi akan membantu dalam melihat atau jangan sampai ada yang miss gitu. Dan sama juga datanya malah untuk chest X-ray itu lebih banyak lagi, 782.000, trainernya 145 lebih radiologis, dan item yang dilihat dari AI ini adalah 124 item. Ini adalah hasil dari laporan validasi yang dilakukan oleh manufaktur sendiri. Jadi ini untuk chest X-ray ini sudah dipublikasi di Lancet bahkan. Oke. Nah, yang kami lakukan di sini adalah melakukan evaluasi multicenter untuk AI ini, apakah memang bisa bergunakah untuk digunakan di lapangan. Jadi ada 3 rumah sakit yang terlibat. Yang pertama itu adalah Rumah Sakit Kanker Darmais tempat saya bekerja, kemudian ada Rumah Sakit M. Jamil dan Rumah Sakit Pusat Otak Nasional. Karena kami mempunyai spesialisasi yang berbeda, jadi untuk Darmais dan Rumah Sakit M. Jamil, kami akan melakukan evaluasi terhadap AI untuk analisis chest X-ray dalam terutama dalam mendeteksi adanya nodul paru. Sedangkan untuk Rumah Sakit Pusat Otak Nasional bersama dengan Rumah Sakit Jamil akan mengevaluasi AI untuk analisis CT brain. Jadi ini adalah tim kami, di setiap site itu ada koordinator, jadi koordinatornya adalah Kepala Clinical Research Unit, yang kami berada di bawah koordinasi dari Clinical Research Center, dan site PI-nya adalah para radiologis kami. Ini adalah study title untuk chest X-ray, jadi memang kita masih menggunakan data retro, jadi bukan prospektif. Mungkin di masa depan kita bisa akan menggunakan data prospektif. Multi-site, jadi untuk setiap use case kita pakai 2 site, dan kita melihat gunanya AI ini untuk membantu interpretasi. Objektifnya adalah untuk mendapatkan real world evidence untuk performance dari si AI ini untuk analisis chest X-ray pada pasien Indonesia. Oke. Dan ini adalah study desainnya. Jadi dari setiap center itu kami mengumpulkan data DICOM gambar, kemudian kita upload setelah diidentifikasi. Nah, data DICOM ini kemudian akan dibaca oleh AI dan juga dibaca oleh para radiologis sebagai ground truth. Selain itu juga kita juga membandingkan dengan original report yang sudah dianonimisasi. Setelah itu kita lakukan analisis terhadap yang tadi item-item yang bisa dideteksi dari AI ini. Jadi tadi yang untuk chest X-ray misalnya 124 item tersebut, kalau ada, kalau nggak ada. Dan ini adalah timeline kita, jadi saya mungkin cuma berbagi suatu penelitian yang baru akan berjalan karena memang kita baru mulai. Protokol studinya baru kita finalisasi di bulan Juli, ethical clearance sudah keluar, dan kami akan mulai data collection sama upload data DICOM-nya di Oktober 2024. Analisis berupa pembacaan oleh radiologis dan sekaligus juga kita harus masukin data dari original reportnya ke template, itu dilakukan Oktober-November. Dan kemudian rencananya kita akan punya laporan hasil penelitian ini di Januari 2025. Mungkin itu yang bisa saya sampaikan, jadi mungkin dari kami sebagai calon user, pesannya adalah selalu validasi dulu. Terima kasih.
Thank you, Dr. Liana, for your insightful presentation. And now we are in the question and answer session. So I just got the information that many of the participants have a plan to catch, and we are learning from AI in this whole day that AI is efficient. So if we start late, we should finish early. So, okay. Well, this Q&A session will be started, and I give maybe a maximum two questions for. First question, please.
Yeah, one question for Dr. Liana. Yeah, why do you choose these two product scenarios, NCCT and X-ray chest? Why do you choose those two scenarios? Are they very, very common in Indonesia, or other reason? And why do you choose analyze? As far as I know, analyze is not the best choice you can make.
Okay, thank you. So the first question is why do we use this? Why do we choose these two use case? Because for CT brain, let me go back to our priority in healthcare. So we have a program, priority program is KJSU, cancer. J is jantung for heart, cardiac disease, stroke, and urology. So two of the priority program is included in this study, which is stroke and also the cancer, because for the chest X-ray, we aim to find a lung nodule. And why do we choose analyze?
Sorry, short interruption. So we also think stroke and lung cancer are the most two important scenarios. But in our practice, X-ray is not a good way to detect lung nodule, right? It misses the ground GGOs a lot. And NCCT for stroke, well, the AI doesn't make too much progress or doesn't help too much in this scenario. Actually, all the negative things you put here, I'm not surprised actually. AI helped a little in NCCT because NCCT diagnosis is so straightforward. That's the deeper layer of my question. I mean, if we want to choose one product that help stroke, the better thing is, for example, something like CTP, or something like CTA, or something like DWI, something like that, that need that diagnosis is not so straightforward. The NCCT diagnosis is too straightforward, too simple. And the better thing to choose for lung cancer, it should be lung CT, right? Yeah, that's my question. Yeah, sorry.
Thank you for pointing that out, because that's what our radiologist said. We should use the low-dose CT for screening of lung cancer. But unfortunately, I don't think we have a lot of CT scan deployed now. So, but chest X-ray is something that is very commonly checked. So at least it can help to detect something. Although, like you said, the sensitivity is very low. But we want to look at how good is the AI in helping us to do maybe to detect the lung nodule with only chest X-ray in maybe a very limited resource setting. But yeah, you have given a very valid point, and that's what our radiologists concern actually. Thank you.
Can I add the comments on that? I think that highlights an important point, doesn't it? I mean, you just can't force AI to make something out of nothing. You have to have the right platform, the right cases in order for AI to be optimized. I guess again, that's the most important thing that we learned today. I mean, if you can't diagnose it with chest X-ray, then the AI won't be good in trying to detect something out of chest X-ray. That's my take on it. I mean, again, I'm very a layman on this topic, but I suppose that's my take on it.
Okay, thank you. Yeah, one last question.
Okay, my name is Aulia. I'm from Jamil Padang. I'm a cardiothoracic surgeon. I want to ask to Dr. Aldi, do you think that if we so good in the robotic surgery, our skill or maybe our muscle memory in the open surgery or the conventional surgery will reduce? That's the first question. The second question, in your slide, you put that to make the robotic or telesurgery more common in Indonesia, we have to input it in the curriculum. Do you have any, maybe some concrete step to do to make that really really input it into our curriculum in surgery in Indonesia?
Thank you again. Great questions. I think the first one, the answer is no. I think it should not decrease our skills at all. I think it has been shown that even moving from open surgery to robotic is much faster than actually moving from open surgery to laparoscopic. I had seniors who have never touched a laparoscope before, but then worked directly with robotic surgery, and it performed tremendously well. I think what's interesting also that there are studies that linked our exposure to video games to actually acquiring skills in robotic surgery, and it shows significant relations. So it's justifying me buying a PlayStation or something. But it's a nice thing. But it shouldn't really affect. I think the main challenges for me, having very early experience in robotic, is that our tactile experience is lost. So whenever I try to sew I work with kidney transplant during the, so whenever I want to pull the thread, the suture materials, and it's a very fine suture materials. When you pull it too hard, then it just breaks, and it takes quite some time to get a feel of the robot. And this is enough, and this is not enough, because we lost that tactile sensation. I think that's the main hindrance for me. The second about curriculum, I think we need my idea is to actually open this to our trainees. You know, sometimes we're not exposed and then we don't talk about it as if it never occurred. I know for sure that in some centers, even CABG was performed using robotic surgery, and I'm sure you know about this also. And it's important that our juniors, our trainees knows about this, because in 5 or 10 years' time, this is the competition that they should deal with. And it's important to include that in the curriculum so that at least they know that those things exist, and that's the dream that they should reach. And sometimes it's just very comfortable for us to just teach whatever it is in front of us. We may not be the most efficient tutor to teach them, but it's important for us to still show them the way if we cannot really practice because we don't have the skills yet. That's the challenge, I think. Thank you.
Thank you. I would like to try to sum up some key takeaways. I see from this session that robotics surgery is better. In collaboration with human with robot, it's even safer. However, particularly in Indonesia, we still face challenges, including the robot is expensive, the internet used has to be superb, the teamwork has to be top-notch, and we still need advanced course to operate that robot. And for the imaging with AI, we see from this session that there are still room for improvement. And at this moment, I would like to thank to our wonderful speakers, Mr. Fang Wenzai, Dr. Renaldi, Mr. En Hao Gong, and Dr. Liana for sharing the valuable insights and perspective. I also want to thank all of you in the audience for your participation and thoughtful questions. Now I would like to give the floor to the MC. Thank you.
Thank you, Dr. Armaji. Ladies and gentlemen, once again, another round of applause. I actually think this session can prolong itself for another session. It was very, very interesting. Thank you. You may return to your seats, ladies and gentlemen. We have come to the end of our program for today, but before that, let's give a round of applause for Bapak Roy Humawan, who is now already with us. We saw him online. Selamat datang, Bapak. Thank you very much. I believe you will be making our closing remarks for today. So.
Yeah, thank you very much, MC, for the opportunity. So, Assalamualaikum warahmatullahi wabarakatuh. A good evening for all of colleagues today. So, to start the final speech, I would like to apologize if this morning video was not run smoothly, because it is not helped by AI. So I have to do it alone, using Zoom in the mid of the night, where the internet signal is very best at the time. So that's my best effort on doing that one. So I do feel sorry if you feel that this morning video is not running very smooth. But that's what happened in Indonesia, where the internet signal is not very stable in continuous time. So colleague, what do we have today that as we conclude this impactful workshop? I want to take a moment to reflect on the profound discussions and insights we have shared over past sessions. Together, we have explored the transformative potential of artificial intelligence in revolutionizing healthcare in Indonesia, particularly in light of the challenges revealed by the COVID-19 pandemic. So, I just have a leisure to discuss with the CEO of Philips International just yesterday before I went to Bali. He said that, Pak Himawan, we live in a very limited situation. So if colleagues who may understand our health system, Indonesia health system, that Indonesia health system is in very limited situation. We have limited number of doctors compared to our populations. We have limited number of healthcare facility compared to our populations. We have limited number of devices, PET CT, SPECT CT, MRI, compared to our populations and needed. So by having this limitation, we should think the most efficient way to deliver our service in the best quality. And by having that opportunity, we have the vehicle now that we call AI. So I guess I agree with what Dr. Rinaldi said previously, that even though we have the AI, but we have to know what is the aim that we want to achieve. If we cannot do by chest X-ray, as Gerdy said previously, so we don't take AI on that one, because something that we not addressed to. So if you agree with me, we should implement this AI. We should utilize this new vehicle of AI to complement us, to fulfill the limited resources, so then we can be able to provide the service with better care to our people in our limited settings. So I guess that is the role of AI that we should agree on. It should not replace the human. It should not replace the human technique. It should not replace the physicians, the specialists, but it should complement them to providing wider services, to providing better services to our people. So that's what the CEO and the result of discussion with the CEO Philips that I take yesterday, and by that sense, that company developing the AI that makes the devices available to be operationalized by health technicians. So where in the space we don't have sufficient medical doctors, the devices available with AI to be operated by the health technicians only, without doctors. And they feel very happy at their setting, at Netherlands setting. So he just explained me on Netherlands, we also face a limited situation on medical physicians. We have limited number of medical doctors, but we have so high demand. So by that, we are creating devices complemented by AI. So then the health technicians that are available in larger number can provide services with the same quality as doctors have. And by having that, increasingly, surprisingly, the doctors also feel happy because they don't have more burden on their life. They don't have to work from 8 to 5. They can be more specific on their focus, on their specialty, without being disturbed by any general case that they shouldn't take on. So it's something that can provide to the health professionals, the AI that we talk today. So our gathering today, organized by Ministry of Health of Indonesia and Tsinghua University, underscore a pivotal moment for our healthcare system. We have seen how AI can enhance preventive care, improve patient outcome, and optimize hospital operations. From early cancer detection in radiology to the innovative use of surgical robots in remote areas, AI is not just a tool, it is a catalyst for change that can bridge gaps in access and efficiency. This is why I told earlier that AI should be addressed to bridge the gaps for access and efficiency. As healthcare professionals, doctors, medical staff, and hospital administrators, you are on the front line of this evolution. I believe in our daily life, you already met with AI. When you open the travel apps, maybe like Traveloka and others, you may see how they develop the application with better response to your need, better response to our demand, than the things that we want to achieve in healthcare. That we want to achieve the utilization of AI that will make our service better to the patients. Your commitment to integrating these technologies into your practice will be crucial in realizing the vision of our vision, Indonesia Emas 2045. By harnessing AI and data-driven approaches, we can ensure that every Indonesian has access to high-quality healthcare, regardless of their geographical location, regardless of where they live, regardless on their their socioeconomic status, and also regardless whether they are having limited situation or not. So let us remember that while AI provides remarkable capabilities, and we agree on this, the human touch remains irreplaceable. As we embrace this innovation, we must continue to prioritize the values of empathy, ethical decision-making, and patient-centered care. The future of healthcare will be defined not only by technological advancements, but by our dedication to fostering compassionate, holistic care. I encourage all of you to take the knowledge again here and apply it in your daily practices. Share the successful case studies and best practices we have examined, and continue to seek out new technologies that can enhance your work. I would like to thank Senior Advisor to Minister of Health for his guidance this morning, Tsinghua University colleague, and all participants that makes this event run in a fruitful manner. Thank you for your active participation and engagement. Together, let us embark on the journey to transform healthcare in Indonesia for the better, ensuring a healthier future for all. At last, safe travels, and I look forward to hearing about your successes as we move forward. Thank you.
Thank you, Bapak Roy Himawan. Would you please stay on stage as we will now take a photo session. Maybe we move up to the center of the stage. As I would like to now invite all the moderators and the speakers who are still in the room. Ya, Pak Michael, boleh. Ibu Dr. Liana, Dr. Aldi, Dr. Armaji. How many moderators do we have in the room still? Oh, there we go, Dr. Donna is still here, okay. Bapak Ibu jangan kemana-mana dulu, nanti kita akan foto ke arah kursi. Jadi kalau bisa merapat malah lebih bagus. All right, let's not forget our smiles. Even though we can AI that into the picture, I do understand that, but let's have a natural human smile. The photographers are gonna let me know once they're done. Sudah? Oh, video dulu, oke. Okay. Seperti di kawinan ya berarti kita ya. Baik. All right, everybody, a big round of applause for the energy given into this room. Ladies and gentlemen, you may return to your seats, but stay put in your seats because we are now, the photographers are gonna come up here. Bapak Ibu boleh lebih rapat duduknya aja yang dirapatkan karena nanti fotonya dari sini nih ceritanya. So all the moderators, speakers, can you please go back to your seats? Thank you very much. Lalu Bapak Ibu dirapatkan. So the cameras are gonna be here. Ya, silakan. Diatur aja Mas. Harus sebelah kiri, kurang ke kanan. Ya, foto wide aja tapi semua kena dirapetin begitu, Mas. Ini udah serapat mungkin. Oke. Alright, everybody smile. Okay, we have the video, the still camera, and the social media camera. These days, there's a camera for almost everything. Wow, freestyle, okay. Smiles, we're in Bali. Sudah? Terima kasih ya Pak. Thank you very much. Thank you. All right, so once again, thank you for all participants. Bapak Roy Himawan, terima kasih for your closing remarks. Distinguished guests, ladies and gentlemen, thank you so much for being here. Thank you for your attendance and your participation. It has been a fruitful and insightful day. At the end of the day, another round of applause to celebrate our humanness. All right, everybody. Thank you very much. My name is Sofina Vita. I'll see you in other medical or AI events, or technology, IT, I don't know which one comes first. But then I'll see you. Safe travels, and if you are extending your trip, have a great stay in Bali.
Recording